ask questions at the end of each talk. We have carved out about up to 5 minutes, depending on how much the speaker will go over. And there are microphones, or we can pass the microphones around. So don't be shy, ask the questions. We try to always encourage folks to not ask questions about their individual case. It's preferred and ideal to talk with your individual provider about that. However, we'll be happy to answer questions about generally educational points about a particular state of cancer and answer any questions that come up generically in the field. And the last thing I will say is it's very important for us to keep improving. So Jonathan and me and the organizers want to learn from you. So please follow and fill the evaluation feedback form at the end so we can give ideas for the future.
So go ahead and pull up the first count there. Huh? You want to start?
Yeah. So
I'll let you click it again.
Sounds great. So thank you, Jonathan. So I will go ahead and start immediately. We have really a wonderful supporter who is sponsoring this event is the Bladder Cancer Advocacy Network. BCAN, it's spelled BCAN, but we pronounce it as Beacon, Beacon of Hope, Beacon of Light. It's a patient organization founded in 2005 by Diane and John Quale, two wonderful individuals. John Quale sadly died of bladder cancer long ago, but Diane, his wife, has been the power who kept this organization alive. And it's really has made a huge difference globally, I would say, about education, research, patient care, information support, advocacy, policy for bladder cancer. We have two amazing individuals here, Gail and Barb. Thank you for being here. Two survivors who inspire us all with their energy and help us with these efforts. And they have a little table outside as you exit on the right. Feel free to stop by, say hi, connect. And we have the Bladder Cancer Walk on May 13. Keep the date in your mind in a beautiful park. All the information is outside in the table. Barb and Gail can give you all the information you need. It's exactly outside this door. And we are going to start with a video by Stephanie Chisolm. Stephanie is the Director of Education and Advocacy in the Bladder Cancer Advocacy Network. Let's see what Stephanie has to say. She's usually here in person. She couldn't come this year, but Gail and Barb represent BCAN, and we're going to hear Stephanie.
Hello, everybody, and thank you for inviting me to speak in Washington on this lovely day in March. I'm delighted to be able to share some information and resources from the Bladder Cancer Advocacy Network. So let me just share my screen. So my name is Stephanie Chisolm, and I'm the Director of Education and Advocacy at BCAN, the Bladder Cancer Advocacy Network. And we know from talking to so many patients over the years that a bladder cancer journey can be very scary. What we're trying to do is really make sure that you have the tools and resources necessary to navigate this scary journey and do it confidently and get the best care possible. So as I start to talk, I want to encourage everybody to take out your cell phone, because the camera feature on your cell phone is going to be very useful for you to be able to access all of the information that I'm about to share with you. So since 2005, BCAN has been in existence when John Quale and his wife Diane were very frustrated by the lack of information and resources available to bladder cancer patients, and especially by the lack of attention in the research community to this very popular, not popular in a good way, but popular in the incidence rate type of cancer. Bladder cancer is the 6th most common cancer in America that hardly anybody ever talks about. So BCAN's mission has always been to provide education and support to those who are impacted by the disease and their families, to advocate both on a federal and state level for issues that are important to people in our community, to raise awareness, because we know from so many people, they never knew that you could get cancer in your bladder until they were diagnosed with it, and then to support research, which BCAN does every year with multiple research awards, and making sure that funding goes on a federal level to research as well. What I always like to tell people is the best place to start is our website. This is our website address, BCAN.org, or if you take your camera on your phone and scan this and push on that little yellow box that shows up on your phone, it should open up on your smartphone to the main page of our website. I like to tell people that we're open 24 hours a day, 7 days a week. So whenever you have one of those, oh my gosh, moments, you can find an answer on the BCAN website. One of the things we list on the website is the incidence rate by state, because you might think you're the only person in the world that has bladder cancer because you don't know anybody else, but know that there are going to be 1,900 people in the state of Washington diagnosed this year. And of those, those are just a small portion of the 82,000 people that will be diagnosed in the United States, over 700,000 people living with bladder cancer. More men get bladder cancer than women annually, and these are state statistics, and up to close to 17,000 people will die as a result of their diagnosis this year alone. So it is a very serious disease, but there are options. When you go to our website, there's a lot of information. I'll be the first to admit it. I put most of it up there, but there's many different ways of learning, and there is a lot of information. So we also created a page for each type of diagnosis. So if you were diagnosed with non-muscle invasive bladder cancer, if you scan this code, you can find out all about what it is and how it's treated. If you have muscle invasive bladder cancer diagnosis, scan the center code, and that will take you to the page that outlines a path for you to learn about your disease. And then if you were diagnosed or have advanced to metastatic bladder cancer, scan the code on your right, and you can find out some of your resources as well. So hopefully you've had a chance to get to these pages. They should save on your phone, on your web app on your phone. On there, you're going to find access to Bladder Cancer Basics, our signature patient education piece. It's available in print, on a PDF, and soon to come an electronic book where you can flip the pages and actually see animated videos to help explain complicated procedures. We have a booklet called Tips for Caregivers, and get the facts pages that have plain language explanations about all of the different treatment options. We also offer recorded videos by medical experts, and sometimes with our treatment talks, that includes a conversation with their patients, talking specifically about treatments that they've gone through for their bladder cancer. All of this information is available free of charge. If you're facing a treatment option or a complicated diagnosis and you just wish you knew somebody else who had the same diagnosis that you could talk to, you could ask to speak to one of our Survivor to Survivor volunteers. If you scan this code on the right-hand side of your page, you will get connected to our Survivor to Survivor by filling out the form on that page, and someone will reach out to you to have a nice conversation, to give you their perspective of what it was like going through a treatment, or some of the questions that they might have wished they had asked when they were diagnosed that you may find helpful. If things get a little bit stressful or a lot stressful, call the Bladder Cancer Support Line. BCAN is thrilled that we're able to partner with Cancer Care to provide a bank of oncology social workers in New York. They're available during regular business hours, East Coast time, and you can access by calling 833-275-4222. You can talk to them about your diagnosis, about having trouble that you might be experiencing with stress or financial issues related to your diagnosis, or if you've lost someone as a result of their bladder cancer diagnosis, you can call them and they can help you find resources in your state, in Washington, or wherever you are. And in looking at trials and treatments, clinical trials are a treatment option. There are many clinical trials being done there at the Fred Hutch Cancer Center by many of the experts that you've heard talk today. And you can find all those trials on our clinical trials dashboard. Here's the web address in the corner. But again, if you scan this QR code, you will get right to that page. You can put in your diagnosis, your bladder cancer type, and the state that you're interested in. Let's say it's in Washington State. You'll find the clinical trials that are open in your state, but maybe you have family that live in Florida, or you have a summer home in Florida. So you could also search down there if that would be convenient for you. And every year in May, it's Bladder Cancer Awareness Month. And every year in May, we have an annual walk to end bladder cancer. We've been coming to the Seattle area for so many years, and it's just a wonderful walk. Gail Dykstra is there to take your name if you're interested, but you can also sign up by scanning the QR code at the right-hand corner of your screen and register to be part of the walk happening in May. And we hope you'll join us. It's a wonderful opportunity to be with a group of people that know exactly what you're dealing with, and also to raise awareness for bladder cancer and help Beacon raise funds to make sure that everything that we do is available to patients free of charge. And if you're free on Friday, March 31st, or Saturday, April 1st, you are more than welcome to join us for a very robust session of the Bladder Cancer Summit for Patients and Families that happens in the spring. We have another one coming up in October that'll be in Nashville. This one, as you see from the cactus, is going to be in Phoenix, Arizona. And all of the sessions are listed on this QR code. If you scan that right now, you can register for any of the individual sessions, including one about sexuality, one about rehabilitation, a session on nutrition, a session on stress, and then a session featuring our co-founder, Diane Qualley, talking to 3 medical experts about what excites them about new treatments that are either currently available or just on the horizon for managing bladder cancer. And if you have any questions, please feel free to send me an email. My name again is Stephanie Chisolm, and I'm the Director of Education and Advocacy at Beacon. And you can reach me at Chisolm, CHISOLM, @BCAN.org. And thank you, and thanks for inviting me. Bye-bye.
So Stephanie has actually been to our walk a couple of times. And last year, one of the co-founders, Diane Qualley, was part of our walk last year. And this coming year, the CEO of Beacon, Andrea Maddox-Smith, will be out here. So it's pretty awesome to have their leadership out here supporting us as well too. Obviously, they have tremendous patient-facing information that they give. As you saw, the website is incredible. We also give a lot of the handouts out when we see our patients and families in the clinic. But also they do a tremendous amount supporting us in research too. And our group at the Fred Hutch and the UW have gotten funding from them as well too, to do some of the research that we're doing. So a wonderful partner that we work with. So I get asked a lot, why did I get this cancer? And unfortunately, we don't have that answer most of the time. But there are some things that put us at risk for urothelial and bladder cancer. And I want to just go through a few of those things. You heard these numbers just in a second ago from Stephanie. Bladder cancer is the 6th most common cancer overall. It's number 4 in men, about number 13 in women. Most people don't know that. They didn't even know you get cancer in the bladder, for example, but it is very common. This shows that there is varying rates of bladder cancer across the United States. And with a darker color having a higher rate of bladder cancer, the lighter colors having a lower rate of bladder cancer. I'm going to come back to this concept with one of my later slides, but you can kind of almost feel like there's a longitudinal risk going on there, which is interesting. As Stephanie mentioned, it is more common in men, about 4 times more common. She showed you these numbers. This is a common cancer, and unfortunately, we lose a lot of patients and survivors to bladder cancer every year. There are also differences by ethnicity. We don't understand this yet, and this is an area of active research for us, but it does appear that in non-Hispanic whites, it's about twice as common as compared to other ethnicities, and we need to understand why this is. Far and away, the #1 risk factor is cigarette smoking. About half of all bladder cancers are caused by cigarette smoking. The deaths from bladder cancer are related to smoking. If people can quit after the diagnosis, it helps reduce the risk of recurrence and progression. Active smokers have a 2 to 4-fold increased risk of developing bladder cancer. Secondhand smoke can lead to bladder cancer as well too. And even when we quit, the risk still persists, unfortunately. So we have looked and seen that 10 years, 20 years, even after 30 years, the risk doesn't go down to 0 again. There still is a slightly increased risk of cancer for years of exposure. So, for example, I'll see a patient and they quit smoking 25 years ago, but they were a 20-pack year smoker. So a pack year is 1 pack of cigarettes for 20 years. That person still has a slightly increased risk over a non-smoker developing bladder cancer, even though they quit. But it's come down tremendously from the 2 to 4-fold increased risk for an active smoker. And we've done some of this work as well. This was a paper that we published a few years ago where we used a Fred Hutch 80,000 person database of non-cancer cases in our area and looked at specific data about smoking cessation, active smokers, and risk of bladder cancer, and showed some of these things that I'm telling you about today. The good thing is smoking rates are definitely declining. These are data from Gallup, the Gallup poll, and you can see this stretches, all the way back from the 40s. And this is the proportion of people, of adults that are active smokers. And you can see from the 40s out through the 70s, about 40% of the population was actively smoking. And then we've seen a steady decline. And over the last few years, 15 to 20% of people are active smokers. This certainly is helping us to reduce the risk of bladder cancer. And as a result, we are actually seeing a decline, a slight decline in the incidence of new bladder cancer cases. Now, this is not as steep of a decline as we saw from people that have stopped smoking. So this is the rate over the last 20 years. And you see it went from 20 cases per 100,000 down to about 18 cases per 100,000. So we're seeing a decrease, but it doesn't quite match what we would expect to see given the rate of smoking cessation that we've seen. So that tells us that there must be other factors that are continuing to be at play in our bladder cancer diagnoses today. And as it turns out, there are a lot of toxins, a lot of carcinogens in the work that a lot of patients do that we're exposed to. Now, why do these toxins lead to bladder cancer? So, you eat, you breathe in, you ingest, gets in through your skin, any of these toxins. Your body and your kidney filter out the toxins, and then your bladder stores these wastes that you're going to urinate out. Now, it does store it. We don't urinate that many times day and night. So you have these toxins sitting in your bladder, repeatedly insulting or traumatizing the bladder. And that's why bladder cancer is so common with some of these exposures. So you can see some of the common workers here: metal workers, rubber industry, miners, jobs manufacturing carpets, paints, plastics, industrial chemicals. Diesel exhaust puts out a lot as well. Firefighters are at a unique risk because of all the toxins created by the fire that they're putting out. And hairdressers are also at increased risk of bladder cancer because of the dyes and the chemicals for coloring hair. Now, if you individually are coloring your hair at home, that doesn't increase your risk of bladder cancer because you're not doing it very frequently. But someone doing years and years of repeatedly dyeing hair is at a higher risk. I will say that there's been obviously improvements through OSHA and every other areas to try to improve our safety around workplace exposures, gloves, masks, filters, et cetera. So, but we continue to see that there are jobs that are putting patients at risk for bladder cancer. And I think as the reduction in smoking is causing fewer bladder cancers, these, as people are all living longer, are becoming more prevalent for what causes our tumors. So drinking water. So again, if we have this concept of these toxins sitting in your bladder, so you're storing them and they're insulting it, then potentially, and there's actually data to support this, drinking more water may reduce the risk of bladder cancer. I just simply think of it as you're diluting those toxins out so they can't be hitting the cells on your bladder as much. And then there are contaminants in the water. Chlorination actually has a byproduct called THMs, which can be carcinogenic, and there are levels of chlorine in the water that are required by the EPA to try to reduce this from happening. And then arsenic is a common bladder cancer cause and a common contaminant in the water. And I want to spend a little bit of time about this. So arsenic is naturally occurring in the Earth's crust. Industrial activity digs it up and it becomes more quantities in our water. There have been some really cool ecologic studies where they took towns that were at the bottom of hills and they started doing mining and things up on the hills. And a few years later, tenfold increase in bladder cancer rates because of the arsenic that got into the water. So WHO and EPA now understand this. And so they've actually reduced the amount of arsenic that we can have in the water. About 15 years ago, they reduced it from 25 parts per billion to 10 parts per billion allowed in drinking water. So this is a map of the state of Washington, obviously, and we were able to get arsenic levels in the drinking water for every source in the state. And the darker colors have a higher amount of arsenic in their water. The lighter ones have a lower amount of arsenic. Now, if you look down at this bottom here, these levels, 1.65 to 7.5 parts per billion are all below the EPA recommended 10 parts per billion, okay? This is a map of incident new cases of bladder cancer in our state. Darker colors, higher rates of bladder cancer. And you look at these side by side, you can start to see that the dark colors do seem to somewhat match up. And so what we did, and we're working to get this data published, is we looked at the different levels of arsenic, again, all of them below 10 parts per billion, looked at the different quartiles of arsenic in those areas, and looked at the risk of bladder cancer, adjusting for other things that might be associated with bladder cancer. And you can, it appears that, if you have, there's not much difference. This is how much the risk is compared to the lowest level. When you get up to 3.6 parts per billion, there's a 15% increased risk of bladder cancer. And if you get into this higher quartile, 4 to 7.5, it's a 23% increased risk of bladder cancer. So potentially, what we need to do is lower the acceptable levels of arsenic in the water even further than what they are currently done. And so hopefully these data and other people validating it might be able to help us to go to the EPA and say, let's do better to improve some of these exposures that we have in our environment for causing cancer. Now, UV light. I'm going to come back to that longitudinal thing. So UV radiation exposure from sunlight and vitamin D. Low vitamin D levels may be associated with a higher risk of bladder cancer. Okay, the main source of vitamin D for all of us comes from our skin, converting it with sunlight. Okay, so we looked at a national cancer registry called SEER, identified incident bladder cancer cases, and then we got from NASA, these are publicly available data, satellite sensing images that give us the UV levels in these different areas. And we can create this map. There's only a few sites that have the SEER registry. We happen to be one of these areas. And you can see the red have a higher UV exposure and the blues, like us, have a lower UV exposure. And some of these states have quite a bit of variation in them as well. And what we saw, and again, we're adjusting for other factors, but these are more exploratory data, that the higher UV exposure was associated with a reduction in the incidence of bladder cancer, adjusting for other factors. And what's even more interesting is that did appear to be difference by race. This protective effect of the higher amounts of UV exposure were attenuated, were lessened in those of Black race. And there is difference in the conversion of sunlight used to vitamin D, which is less in those that have more pigment in their skin. I think that actually even strengthens the fact that this may be a real observation, but more work needs to be done, and we're still working through some of the data too. These are unpublished data, but I think they're exciting for what we can do to study to try to understand more about bladder cancer. We've done other things too. I'm a huge believer in the role of diet and exercise, nutrition, and the risk of cancer. We have tried to do some work to look at supplements, and unfortunately, we haven't seen in this study that we did a few years ago, we didn't see any supplement or vitamin level associated. Now, of course, some of this might just be what we call a power issue. We don't quite have enough cases to show a relationship. But again, just exhibiting that we're trying to understand this. And we also did a paper looking at anti-inflammatories, NSAIDs. So people take aspirin, ibuprofen, Advil, naproxen, and there's certainly data to suggest that these may have some anti-cancer, anti-inflammatory processes in them as well. We looked at 10-year exposure to non-steroidal anti-inflammatories and looked at 77,000 people in our state who didn't have bladder cancer. And what we found that if you were a former smoker, higher use of anti-inflammatories reduced the risk of bladder cancer. So why former smokers? I think in the non-smokers, the risk of developing bladder cancer was pretty low. So adding this protective anti-inflammatory doesn't have much of an effect. If you're an active smoker, you have so many insults coming into the bladder that the anti-inflammatory can't overcome those insults. But if you're in that non-smoking group where your risk is starting to come down over time, maybe adding this anti-inflammatory effect can reduce the risk. So interesting things that we're doing. So overall, bladder cancer unfortunately is common. The incidence is declining, which is fantastic, and is likely a lot related to declines in smoking. But however, other exposure is still causing us to get bladder cancer. And we're trying to find new ways and new things, not only to identify, but how to prevent those from happening. So with that, I think we might have time for a couple of questions. Anything in the chat, Petros?
I don't see anything that's
No questions is fine too. We can stay on task, and you can grab me at the break too. Yes. With the question is bladder cancer associated with colorectal cancer? So the rectum is right next to the bladder. I did not talk about genetics. We're going to be hearing about that, and there sometimes can be links there. We do know that one of the rectal cancers are often treated with radiation as part of the standard treatments, and exposure to pelvic radiation does increase the risk of subsequent bladder cancer because the bladder is in the field of the radiation that comes in. It's a low increased risk, but as far as are the two linked, and of course, I mean, you may be getting at the fact that, you know, we're putting out the waste in our diet too. Yeah. So, and there are certainly certain diet and exposures that directly lead to both upper and lower GI tumors as well. So, great question. One more, yeah.
It seems that what you're saying is there's probably a discordant risk with bladder cancer versus lung cancer and the smoking and ex-smoking population. Can you explain?
Yeah. So the question is, why is there a little bit of discordant between bladder and lung cancer? And I think what you're getting at, I think, is that after 20 years of quitting smoking, the risk of lung cancer goes down. I think, and the way I would think about it is that with the lung cancer, you breathe it in, you breathe it out. So there's less contact exposure of the toxin, whereas, you know, you filter it in and it sits in your bladder for longer. So the bladder has a longer exposure to those toxins as opposed to just the passing into the lung. That's my thought on that. So, but you're right. That was one of the most interesting findings and it's come up repeatedly is why does the lung cancer risk go back to zero or back to the non-smoker, whereas bladder doesn't? I think it's duration of the toxin exposure. We have time for one more?
one more.
Yeah.
When it comes to arsenic in our water.
Yeah.
Is it filtered out and use these water filters, Petros, and all these filters you see on the market?
Yeah, I don't know. I should look that up. So, and I will. So thanks. Yeah, you do. Yeah. First stump of the day. That's perfect. All right.
I suppose for the non-steroidal inflammatory drugs,
Yeah.
more research is needed, right?
Oh, absolutely. Again, these are in many ways just provocative things. And I wouldn't recommend starting to take an aspirin or chronic non-steroidals without talking to your doctor first. And obviously there are risks associated with those too, the role of anti-inflammatories in reducing cancer. In more, it was a sense to highlight some of the things that we're doing and how we're trying to understand these and the tools we have at the Fred Hutch to do this, and thought-provoking ideas as well too. So thanks, Becca.
Thank you, Jonathan. Fantastic talk and eloquent and so much information in a short amount of time. And actually, this fits very nicely with the next speaker. So Jonathan covered perfectly the environmental risk factors for bladder cancer. You know, cancer is a disease that has to do with environmental risk factors, as Jonathan nicely said, and sometimes genetic factors, right? That may be some genetic predisposition to cancer that may or not play a role. So to cover that aspect, we have Lauren Puryear. Lauren is a genetic counselor at the Genetic Medicine Clinic at the University of Washington. We're very honored to work with her. She helps us a lot with our patients, and I know I'm a frequent referrer to you. So may I answer also part of your great question about colon cancer and bladder cancer, in addition to what Dr. Wright mentioned, maybe some genetic links as well. Lauren.
Great. Thank you. I'm very happy to be here today to talk about hereditary risk for bladder cancer. Obviously, I'm just going to skim the surface of this topic because genetics is a huge topic in cancer risk. And I have no conflicts of interest to disclose. So I'm going to start out by taking you back to high school biology very briefly to remind you that in most types of cells in our bodies, we have a complete copy of our genetic information. You can see in this diagram, it's sort of bundled up into these packages called chromosomes. But if you spread out a long strand of that DNA, you can see that it's just a sequence of DNA building blocks. And a gene is a segment of that DNA that has building blocks in a specific order so that the cell can look at those instructions and know how to make something that it needs. This could be making an enzyme that helps you digest milk, or it could be making a type of collagen that goes into building bones or blood vessels. Or it could be making a protein that acts as a tumor suppressor that helps to protect that cell against growing and dividing out of control and becoming a cancer. Sometimes people can have a difference or a change in that sequence in a gene. We call this a genetic variant or a mutation. And there is a lot of genetic variation between people. We've all got lots of these variants and lots of genes that just are harmless differences between people that make us who we are, and we're all different. But sometimes you can have a difference in a gene that stops those instructions from being used by the cell. So it changes them enough so that the cell can't make the product it needs from those instructions. When we think about cancer developing for a person who does not have a hereditary cancer risk, they don't have a germline mutation, something that was inherited, that situation is shown in the top of this diagram. So they've got 2 copies of a tumor suppressor gene that encodes one of those tumor suppressor proteins that are really important protection. They got 1 copy from each of their parents, and both copies of that gene are working. The instructions look the way they should, and the cell can use them to make the protein. If by chance, one of those copies of the gene gets damaged, because DNA damage is very common from environmental exposures and just from normal processes in the cell, that cell is still fine because it's still got the protection of that second copy of the gene. It's still got working instructions that it can use to make the protein it needs. However, if the second copy of that tumor suppressor gene in that same cell gets damaged, then that cell is no longer as well protected from becoming a tumor. It may start to grow and divide out of control. You can see that for somebody who has a hereditary cancer risk or a germline mutation in the bottom part of this slide, they are starting out with 1 hit already. They've got 1 non-working copy of that tumor suppressor gene in all of the cells of their body. And so it's a shorter pathway and a higher chance that they'll have a second hit in one of those cells that knocks out the other working copy of that gene, and then that cell might go on to develop into a tumor. So there is genetic testing available that can help sort out whether somebody has a hereditary cancer risk. And that's called germline genetic testing, because the germ cells, the sperm and the egg, take the genes from one generation to the next. And so if you inherit a hereditary cancer risk from a parent, that's a germline mutation or a germline variant. And you can see my one statistic of the talk up here that up to maybe a quarter of people with a urothelial cancer diagnosis may have a germline genetic variant that we can find, and they might have a hereditary cancer risk. And that can be very important for them and their family members to know. That still means that the majority of people with urinary tract cancers don't have a genetic risk that we can identify. So most people have bladder cancer, urothelial cancer because of the other factors that Dr. Wright talked about. Another kind of genetic testing that you might encounter is tumor testing. So looking at a sample of that cancer to see if there are mutations in those cancer cells. And that can be very helpful for treating oncologists to try and target a treatment to whatever's going on in that cancer. There are some drugs and treatments I'm sure you'll hear about today that are more effective if the cancer has specific types of mutations. The third type of genetic testing I just want to mention in case it comes up for anybody is called liquid biopsy. This is not used as commonly now, but I think it's going to get more and more common as the technology gets better. And that's looking for little tiny bits of tumor DNA that have spilled out of dying cancer cells and end up circulating in the bloodstream. They don't do any harm. They're not in a cell. They can't do anything, but they can be an indicator of what's going on with the tumor that doesn't require an invasive biopsy to actually get tumor tissue. So this is just a visual representation of those three types of testing. So germline testing is looking for something that a person has in all of the cells of their body. Somatic or tumor testing is looking just at the tumor. And then the liquid biopsy is looking for that circulating tumor DNA. So how do we know if a person has bladder or urothelial cancer, whether they should think about talking to genetics? As we said, most cases are not caused by a genetic risk that we can identify. We get more suspicious that somebody has a hereditary predisposition to cancer if we see a diagnosis at an unusually young age. We also occasionally will see people in our clinic who have had tumor testing that identified a mutation that the lab thought, this might be a germline mutation because we've seen this mutation before in germline genetic testing. So sometimes on the tumor report, it will say, hey, you should follow up and get some germline genetic testing. The third thing that I think about that's very important is to think about the person's family history. So hereditary risk, of course, runs in families. And so sometimes you can see a pattern of multiple people in the family with the same type of cancer, or people in the family with related types of cancers. And the colon cancer question was an excellent introduction to this idea. So the most common condition that causes increased risk for urinary tract cancers is called Lynch syndrome. And it also increases risk for a number of other types of cancers. So if I take a family history from somebody and I see that they have relatives with colon cancer and uterine cancer and prostate cancer, that to me looks like a pattern that might make me think about Lynch syndrome, especially if some of the relatives were diagnosed at younger ages. And I want to highlight that the highest risks for cancer in people with Lynch syndrome are for colon cancer and for uterine cancer. So I'm especially looking for those cancers if I'm thinking that somebody might have Lynch syndrome in the family. So if you do nothing else, healthcare providers who are listening, ask somebody if they have a family history of colon cancer or uterine cancer. All right. And finally, what do we do if we identify a hereditary cancer risk? How does that help? Occasionally, it can be helpful for directing treatment. So sometimes that helps oncologists, although more often that tumor testing is going to be what's helpful with that. Germline test results can be very, very useful for the second reason shown here, which is they can tell us we should be screening a person for other cancers that we might not have suspected that they don't already have, but we might want to watch out for. So for Lynch syndrome, it's recommended that people have a colonoscopy every 1 to 2 years, which is a lot more frequent than in the general population. So that can be a life-saving additional screening that we might add for somebody. And then finally, one of the most important reasons that people come in to see us is they're worried about their family members. I can't tell you how many people I've seen who say, I'm fine, I'm getting treated for my cancer, I'm worried about my kids. Is this going to happen for them? Do they need to be doing something that they're not already doing? And so if we identify a hereditary cancer risk in one person in a family, then we can offer testing for that specific mutation in that specific gene to anybody else in the family who wants to know their risk. All right, I'm going to stop there because I know we've got probably some questions about genetics. Yeah.
I have a brother with cancer, bladder cancer. I have bladder cancer as well. I have a twin with the same DNA, but she does not have.
Yeah. That is a great question. So
Can you repeat the question?
yes, the question was that somebody has a brother with bladder cancer and they also have bladder cancer, but then they have a twin who does not have bladder cancer. So identical twins have the same DNA to start out with, right, as tiny embryos. But what happens after that is different. You're unique individuals. And so if you think about that two-hit hypothesis of cancer development, sometimes by chance, somebody will have a cancer develop because, you know, one copy of the gene got knocked out and the other copy of the gene got knocked out in a specific cell. And twins aren't necessarily going to have that happen at the same time. Yeah, that's an excellent question. You can certainly both have an increased risk for bladder cancer. And it sounds like, you know, you have a family history that might make people concerned.
If the patient can't presume
Yes, families also share environmental exposures as well. So smoking and secondhand smoking, you know, for people within a household, water in the household, vitamin D, all of those kinds of things. Yeah, great question. Anything else?
We're doing a lot more of the somatic testing of the tumor to try to direct therapies. And are there times where you do the somatic testing where it might prompt to do the germline?
Yeah, absolutely. If somebody does, excuse me, a tumor test and the lab identifies a mutation that's very commonly seen in Lynch syndrome, and they say, we've got lots of families who have Lynch syndrome because they have this mutation in their germline, then the lab will say on the tumor report often, this is potentially a germline result, but we don't know because we've only looked at cancer tissue. So please go see genetics.
Lauren, very quickly, can
Yeah.
you comment about the cost of genetic testing?
You kind of repeat the
Yes.
question.
The cost of genetic testing is a very good question. So more and more insurance plans are covering genetic testing when people meet certain criteria. So young age of diagnosis, family history pattern that looks like a particular cancer syndrome, those things can help. There also are now a lot of laboratories that have patient access programs. So they offer financial aid, they offer payment plans, and some of them have low cost testing. By low cost, I mean about $250, which is much lower than genetic testing used to be. And so there are a lot of options that didn't used to exist. All right.
Thank you so much.
Thanks.
I'm next going to invite my partner, Dr. Nyame. Dr. Nyame is a assistant professor in urology, also has an appointment here at the Fred Hutch, and also takes care of veterans over at the Seattle VA hospital. He has a robust research program too, and takes care of a lot of bladder cancer patients. So we've asked him to talk about some of the new exciting treatments that are coming out for non-muscle invasive bladder cancer.
Good morning, everyone. I want to start by thanking Dr. Wright, Dr. Grivas for giving me the opportunity to speak today. I have to say, in my clinical and research practice, it's these events where we get an opportunity to be with patients and share what we're doing as a program that is really exciting for me and a privilege. I was going to say all the things that Dr. Wright said about my clinical practice. I treat urologic oncology patients at the VA and at the university and treat bladder cancer as part of that. You know, today in discussing novel therapies, I wanted to start really quickly with sort of how we get to treatment for non-muscle invasive bladder cancer. And I always say, if we start with what are quote normal cells, you know, they're same shapes, same sizes, they're really organized and a very predictable architecture. You know, when we talk about low-grade tumors, we start to have a little bit of more abnormal architecture, okay, but still you can sort of recognize what the cells look like. As they become more disorganized and more abnormal in not only the way that they are shaped together, but also in the way that they look, we start to think that those tumors are high grade. And when we talk about invasive versus non-invasive, really what we're talking about is this layer here, this muscle layer. And so we have three main classifications of non-invasive. We have those flat tumors, you'll hear CIS. We have TA tumors that are just on that inner lining of the bladder. I always say the inner lining of the bladder is like the inner lining of your mouth. And if it goes between that first layer into this lamina propria, which is this layer between that inner lining and the muscle, that's that T1 tumor. And so what you can see just in 2 slides, we have a lot of heterogeneity in the way that our cancer of the bladder can present. And that gives us both different opportunities for treatments, but it also gives us different challenges, right? So how common is non-muscle invasive bladder cancer. We have about 83,000 new cases of bladder cancer diagnosed in the US, estimated for 2023. About half of those are going to be non-invasive. So the majority of our patients are presenting with non-invasive cancer. And when we think about what are our treatments, the first mainstay is going to be this TURBT. And you can see this picture here. We have that thin loop of wire that we have an electrical current coming through, and we're going to shave a piece of the bladder to get our diagnosis and in many instances start our therapy, right? And one of the reasons I wanted to show this is you can see that what we're hoping to do when we take this shaving is to get the tumor, that lamina propria, and a little bit of that muscle as part of our specimen. So if you ever had to have a second resection, it might have been because we didn't have that muscle, right? Because we want to make sure that we accurately stage you. And the other reason that we might go back and do another resection is we have some studies that suggest about half the time when we go back and resect a second time, we find more cancer. So, and that might correlate with better response to therapy, we think. So these are the risk groups. I want everyone to pay really close attention. I'm going to quiz everyone later. The reason I put this up is just to show that there's that variation, right? And we tailor treatment based off of your risk group. Low risk is basically low-grade tumors that are pretty small and pre-cancerous lesions. High risk is going to be T1 high-grade cancers that come back, cancers that are larger, or multiple areas in which we see cancer. And obviously medium or intermediate risk is going to be everything in between. And the reason that that's important is the therapies that we recommend in this stage vary by your risk, right? If you're low risk, most of the time we give a dose of chemo after that resection and we watch you very closely. If you're high risk, we're doing BCG for 6 weeks, and then we're doing maintenance up to 3 years. And for medium or intermediate risk, we're thinking either chemo or immunotherapy for induction, and then 1 year of maintenance therapy. And then as part of that, we do surveillance with cystoscopy. Well, I'm going to transition now into our novel therapies in this space. And the first thing I wanted to point out is really where we've been and where we are now. This is a New York Times article from 2016. It saddens me to say that this is still an issue for us. But drug shortages, we've had shortages of BCG that really have put a strain on our patients, and they've certainly put a strain on our health systems as well. And one of the reasons I wanted to point out this particular phenomenon is that it's had an important impact in our discovery of new therapies, because it's changed the standard for what we think new therapies have to be. For a long time, we thought new therapies had to be better than BCG, but I think now we're just looking for alternative drugs that we can use to supplement treatment in the face of these shortages. And it actually has allowed for a pretty big explosion of novel therapies in this space. This is what things have looked like over the last 7 or so years. We have a lot of therapies that are coming into the mainstay. We have trials like this BCG Prime that was just looking at a different strain of BCG that was part of a SWOG trial that we participated in. We have this new bridge trial that we're really excited about that we're also opening here at our center. We've had systemic therapy, so that's in the high grade BCG naive space. In the unresponsive space, we've seen a number of medications come in, including this Adstiladrin, which we're really excited about, this ALT-803 plus BCG. And I'm going to go through very quickly a little bit of data, but this slide is really just to highlight how much we're trying to do. And there are even more trials that are coming in and some that we're leading here at our center. So other things we're thinking about is how can we make the current therapies that we're delivering more effective? And so there are a lot of different modes of delivery. Some of those trials that I showed you are looking at chemotherapy in a gel. They're looking at new ways to tag cancer medications that can be pretty toxic to an antibody, for instance, that will allow it to be more specific in attacking cancer cell, and that can increase tolerability of therapy. So in the BCG naive space, we have PRIME. I'm really excited to have the readout of this trial because it'll give us another BCG option. And this was a trial that we participated in and has since closed. We have Bridge, which I mentioned, and it's comparing a combination of gemcitabine and docetaxel, which we've been using in the second-line therapy, mostly based off of retrospective institutional data. Folks have used it, they say it works, but nothing has been done rigorously in that prospective fashion where we randomize patients. This is going to randomize almost 900 patients who have newly diagnosed high-risk bladder cancer to these two treatments, and really is going to be a practice-changing study for us. And we come into it with some data to suggest that gemdosi, at the very least, is just as good as BCG. So this is from the University of Iowa, and you can see what the response rate at 12 months was for gemdosi, 85% recurrence-free survival versus 71% for BCG. But we have to take this kind of data with a grain of salt. That's single institution, and all it's retrospective. Are the two groups really comparable? So that's really what Bridge is going to answer for us as we move forward. In the BCG unresponsive phase, I think what we've had for a long time was BCG. And if you have a recurrence or don't respond, we try a second-line treatment or a clinical trial, and pretty quickly we're thinking about cystectomy. And part of that is because cystectomy is really an effective treatment for non-muscle invasive bladder cancer. And so I think many of us don't want to miss that window when we can still offer cure at the risk of providing harm with therapies that are not effective. I just showed you that schema of all the trials that we have. I think our new paradigm is going to be that we're going to have a second and a third and a fourth line therapy, all of which could be really effective. And I think work that's being led by Dr. Wright and others across the country is going to take us one step further when we're going to have biomarkers that really help us determine, out of all the options we have, which therapy is going to be most effective. So here are some new options in the unresponsive space. I will go very quickly through them. The pembrolizumab is an immunotherapy that's given IV as a systemic therapy. That has its own challenges for administration. The efficacy, 20% complete response rate at 1 year. We have Adstiladrin, which we can see here has a fairly good response rate at 24 months. One of the advantages of the Adstiladrin might be the dosing and the toxicity, what the side effects are. Those are both really favorable. We have gemdosi, which again, we don't have prospective trial data on, but that has been a standard that we've used for a long time. And then we have this N803 plus BCG, which has really good response rates in the clinical trial, but tolerability was a little bit lower or what would you say, the side effects were a little bit higher compared to what our standard of care has been. So a lot of exciting therapies in the horizon in this space, and I think these are all going to be really game changers for our patients. Here at the Hutch, we're going to be investigating this drug, enfortumab vedotin, which has really become a new and really helpful medication in the metastatic phase. And I think this is one of those areas where you could see the great leadership that we have in our program helping us to innovate to hopefully make a difference for patients and add new therapies in the space. So in conclusion, half of our patients are going to present with non-invasive cancer. Treatment really depends on the risk, and I think we're really coming up with more and more options to tailor treatments based off of risks. Drug shortages are really a big strain. It really impacts the lives of our patients and certainly our system. But we have a lot of exciting clinical trials, and I think we're going to continue to see innovation lead to positive change for our patients. So with that, again, thank you for giving me the opportunity to present this morning, and I'm happy to take some questions.
I have a question about non-invasive patients. Is the non-invasive presentation for about a day or given enough time to pay them up?
Great. So the first question for that non-invasive is low grade, high grade. Because
the question.
The question was, by nature, is non-invasive bladder cancer gonna stay non-invasive essentially. And it really, the first question that I always, or the first thing I highlight to patients when we go through that pathology is the low grade, high grade. Low grade cancers tend to be the nuisance of recurrence. So they come back, but they don't tend to progress, whereas high grade cancers do both. And so with a high grade cancer, part of the reason we're initiating all of these therapies is we're trying to decrease the chance that it comes back within the bladder, but also that decrease the chance that it becomes either invasive into the wall of the bladder or spreads beyond that.
And you've been doing it for 7 years. Will that knock you out of the trial? I mean, is this trial for just people that just get cancer, or is it for people that have been fighting it for quite a long time?
Yeah. So some of the trials are good. Do you want? Oh, sorry. I'm going to repeat the question for those online. So how do you get into these trials? Are they only for people with new diagnoses? Are they are people who've had bladder cancer for a while and might have, for instance, a recurrence eligible? And you're going to have eligibility criteria for trials that are going to meet both populations. So there are going to be some instances that if you've had a recurrence, for instance, and you meet certain criteria, you would be eligible to participate. How do you get into the trials? You know, hopefully our team is presenting what's available at our institution to you when we see you.
Have a question online, but we let the audience. Are some of these trials have to be not or
yeah. So there are some systemic therapies, there are some combination therapies. I didn't go into specific details. I mean, there are some that are looking at priming patients with something under the skin to boost the immune system, plus intravesical. So there's a wide spectrum of medications that are being investigated. Obviously, when we give things systemically, the side effects can be a little bit more. And so I think a lot of us are thinking about things that are local therapies inside the bladder primarily.
Thanks, Jonathan. Yeah, fantastic talk. Thank you for being here, for all you're doing. One great question from the chat room. Should we do biomarker/tumor DNA kind of somatic testing to identify potential trial options and treatments? This particular question is for BCG and responsive disease, but I suppose it applies to anything.
I mean, I feel silly answering that question with Dr. Wright next to me, because this is, I mean, this is an area where he leads. I think we're not there yet, right? But I think that's where we want to be, in an area where we can look at what the biology of the cancer is and really tailor a treatment to what is available that we know works, right? And I do think we're making really big inroads towards that. Right. Thank you.
Thank you.
Gonna next have John Gore come up. John Gore is another one of my partners in urology. He's a professor at the university, also here at the Fred Hutch, and he leads some national programs in bladder cancer research, one of them CISTO, that he's going to describe for you today. So John, thanks for being here.
Thank you very much. And it's great to see everybody here in person and also online to those of you that are logged in. That was a really great overview of a lot of what's going on in terms of contemporary approaches to non-muscle invasive bladder cancer. There's this idea, though, that, you know, as Dr. Nyame discussed, that some of these patients that have non-muscle invasive bladder cancer, we are concerned that if what we give to them doesn't work, that while we are treating them, the cancer could get worse. And this idea that maybe we have this window of cure that we want to take advantage of. And so for a lot of these patients, we are actually trying to debate between some of these novel therapies or clinical trials and more aggressive treatment like bladder removal for these non-muscle invasive bladder cancers. So I want to talk to you about something that we are leading that is a national study that is trying to compare an aggressive intervention for a non-invasive cancer with sort of a hodgepodge of medical therapies. This is sort of me up here talking about a really big team. So this is a collaborative that takes place across the United States. The main administrative team is here at UW in the Hutch. And I really love this quote. This is based on sort of the genesis of something called PCORI, which is the Patient-Centered Outcomes Research Institute. And it's this idea that now we have a panoply of treatment options for a lot of the cancers we treat. We really need to figure out how to match the right treatment with the right patient at the right time in their care. So how can we better personalize the therapies that we deliver? So why did we come up with this project CISTO? Well, first of all, it's the best acronym I've ever been a part of, and I wish I could take credit for it. Those of you that have been engaged with bladder cancer for a long time are very familiar with the procedure of CISTO. CISTO stands for a comparison of intravesical therapy and surgery as treatment options for bladder cancer. And the why is because patients recognize that the questions we're going to answer in CISTO are really important questions. These are results from the Bladder Cancer Advocacy Network Patient Survey Network, where we ask patients to tell us what research questions are important to you. And you can see that the top two related to, gosh, how do we make decisions about radical cystectomy? And what are the best treatments when BCG is no longer working? But you know what? It's also a challenge for us as clinicians. These are some representative quotes from members of the CISTO collaborative that just show you that this is a conundrum for us too. And we're not always sure what the best treatment is to offer patients when BCG doesn't work. So it's a patient-centered problem, but it's also a clinician-centered problem. And then who are we talking about? You know, we talked about clinical trials. Clinical trials often have these very narrow definitions of who is eligible. And so if you look at that left-hand column, that is a very classic clinical trial patient. They have an initial diagnosis of cancer, they get BCG, their first checkup looks reassuring, they get some more BCG, and then they have a recurrence, and we sign them up for a clinical trial. But the right-hand column is an actual patient of mine, and that is more representative of some of the histories that we're seeing in our practices. They get this line of therapy, maybe their cancer comes back. They get that line of therapy, and now their cancer comes back, and now what do we do? So philosophically, it's not as much about BCG unresponsive non-muscle invasive bladder cancer, which is a very specific definition. It's more about the conundrum of how we manage recurrent, high-grade, high-risk non-muscle invasive bladder cancer. And then, you know, we often try to construct these sort of tightly controlled environments of a clinical trial. And the reason is that when we start to engage real-world data, it gets messy. This is a quote from a patient advocate that was speaking at a radiation oncology meeting, and she said, you know what, I get it, it is messy, but so are our lives. You know, our lives are messy, so this real-world data is really important. And then also importantly, what? You know, when we think about comparison of treatment A to treatment B, what's important? Well, we thought, gosh, maybe we should just ask patients what's important to them. And what you can see here is that some of the constructs of what patients think are important match what we as clinicians often think are important. You know, what's the risk that my cancer is going to spread to become a metastatic cancer? What's the risk that this cancer is going to be life-threatening to me? But there are some constructs on there that we don't necessarily always think about. You know, how is this going to impact my quality of life, but also how is it going to in fact impact the burden on my loved ones? You know, whether it's my spouse or my kids or my friends, and then how is this going to affect me financially? So it turns out when you ask patients what's important to them, you get some answers that are maybe different from some of the things we think about. And then lastly is the how. You know, how do we do these comparisons? Classic clinical trials are randomized controlled trials. You know, you are assigned to treatment A or treatment B based on the flip of a coin. But some comparisons we just can't do a randomized controlled trial for. And here, we're trying to understand the role of a major surgical procedure, bladder removal surgery, compared to some treatments that allow people to keep their bladders. And most patients wouldn't sign up for a flip of a coin deciding between those two categories. And when we actually asked patients, you can see that only 10% of patients said they would sign up for that kind of clinical trial. I actually think that's probably an overestimate. So what is CISTO? Well, CISTO is a comparison of radical cystectomy, that's bladder removal surgery, with bladder sparing therapies. And it used to be intravesical therapy, but when we got this trial funded, the FDA approved pembrolizumab for non-muscle invasive bladder cancer, and that's delivered as an IV treatment. So now it's intravesical and immune oncology treatments. And our main outcome is a quality of life outcome. But you can see that we're also going to assess things like bladder cancer specific survival, the chance of the cancer coming back, and then some additional quality of life outcomes like, gosh, do I regret the decision that I made? How is my urinary quality of life? Whether I urinate into a bag because my bladder has been removed, or, what is my urinary quality of life after I've now gotten an additional, 12 therapies into my bladder. And then financial toxicity. Bladder cancer has been shown to be the most expensive cancer per capita in men and women. And a big reason why is the frequency of visits, the invasiveness of the monitoring procedures, the use of CT scans and MRIs and a lot of advanced imaging. And so how does this burden, our patients? So this is what we would call a pragmatic trial. And a pragmatic trial is trying to kind of get at that real world question. And it's very different than what we would call an explanatory trial, which is most of what our clinical trials are. Rather than trying to create this tightly controlled environment, we're trying to see how these treatments work in a broad sample of patients in diverse practical settings. And because of that, you need a really big sample size. While we were planning CISTO, it just so happened that Jim Cotto, who's on our external advisory board, was doing a feasibility trial of a randomized controlled trial for the exact same comparison that we were looking at. And it turns out they weren't able to proceed with the randomized controlled trial. So for us, this was a really great validation of our study design for CISTO. We thought that a randomized controlled trial couldn't be done, and it turns out that we were right. So where is this taking place? Well, we are up in that upper left-hand corner, but you can see stars all over the United States. We represent all US Census regions, and the blue sites represent community sites, because most bladder cancer care occurs in community urology practices. And this is our enrollment up through February 28th, and it shows that on a monthly basis, we're enrolling about 15 to 16 patients. And this is really exciting because this means that we are going to have the capacity to make really, I think, meaningful comparisons between these two groups. This just shows some of the unique and I think really interesting data that we're going to get from CISTO. So this shows the salvage medical treatments that patients have been getting from the start of CISTO in early 2020 all the way up through 2022. Unfortunately for us, we launched this study in March of 2020. And as you guys may remember, that also was when COVID struck. And so those first couple bars you can see are pretty meager. But what is really interesting is Dr. Nyame was talking about gemcitabine docetaxel as a combination therapy that we give into the bladder. That has become in that dark blue bar sort of a fairly dominant salvage strategy. So this is almost going to allow us to be a surveillance system to understand how are urologists managing recurrent non-muscle invasive bladder cancer. And so what CISTO, I think, represents is this idea of patient-centered study design. But also, we're not just selecting outcomes that we care about as clinicians, we're selecting outcomes that patients care about as well. And in that way, by using the study design that responds to patient priorities and preferences with outcomes that are important to patients, we're going to come up with generalizable results that I think are going to be meaningful, not just to us as we try to navigate the decisions we have to make, but also to our patients. So thank you very much.
Fantastic, as always, wonderful and such an exciting study, pragmatic. Questions? I know Dr. Wright is looking at the chat room. John, can you tell us a little bit more, what do you estimate this trial, pragmatic trial, to be completed? And how do you envision that informing the next steps?
So we are continuing to enroll patients. Oh, sorry. The question from Dr. Grivas was, when is this trial going to be finished? So when will I be able to come back to this audience and present some results? And what are some key things I think that this study is going to represent? Well, number one, we're going to finish enrolling patients in September of this year. 1 year after that, we'll have sort of our initial snapshot of results. So by 2024, we'll have some initial results to present. What is really unique about CISTO is the inclusion of a radical cystectomy patient population. As we think about a lot of the new clinical trials that are being planned in this space, none of them include radical cystectomy as a comparator. And the reason is it's too hard to do. As I just showed you, you can't do it as a randomized controlled trial. So CISTO is going to continue to operate in this unique space where we're going to have the ability to compare some of these newer therapies to radical cystectomy, which truly is one of the harder decisions that we have to make as clinicians, but also that our patients have to make. You know, when we offer a radical cystectomy, sometimes when we offer stuff, we're offering it, but we're not really offering it. Sometimes when we offer it, we really think it's the right thing to do, but it's hard to know from your perspective if it's the right thing to do. And CISTO is going to operate in this really unique space where we're going to answer some questions that I think are going to be really helpful to patients and to doctors. Yes, ma'am.
Does your CISTO study also go beyond the bladder? So when it becomes metastatic and the body also look at it started giving other things. Is it monitoring those patients?
We do. So we follow patients truly as long as we can. One of the things that we're planning, and I'm partnering with Dr. Wright on this, is to try to extend. So CISTO is funded by a grant, and the difference between a grant and say an industry sponsored study or a study sponsored by one of our cooperative groups is it has an endpoint. There's a point at which I'm no longer going to get money to support it. So we have some different parameters for the time we can invest into enrolling patients and following them. So we're planning a follow-up grant to try to continue to collect data on these patients, because the main outcome in CISTO is a 12-month outcome. But as many people in this room know, gosh, we really would benefit from understanding the outcomes of those patients 2 years, 4 years, 5 years after they had this really important decision. So we do continue to follow them. We track what happens with their cancer. Does their cancer come back? Does their cancer worsen? Do, God forbid, patients die of these cancers? And so we are tracking all those outcomes. Thanks.
Anything in the chat?
All right.
Wow.
Thank you, everyone.
Thank you so much. Fantastic. Okay. So we're doing so well on time so far. I'm very happy about that. We have so much content. And I appreciate everybody's participation and questions. I think is wonderful. So keeping us on track here, we're going to switch gears, and we're very, very excited to talk about multiple aspects of care, in addition, of course, to treatment, anti-cancer specific treatment options, but think about holistically, comprehensively, how else can we support the patients? And we're very thrilled to have Dr. Matthew Givens, who's a physician here at the Fred Hutchinson Cancer Center. He's an assistant professor in the clinical research division, and Dr. Givens will talk about palliative care. And palliative care has multiple aspects, and it's across the continuum of treatment of the patient. Matt, the floor is yours. Thank you for being here.
Good morning. My name is Matthew Givens. Again, I want to thank Dr. Wright and Dr. Grivas for allowing us to speak today. I'm hoping today to go over a few things, but I have 3 primary objectives. 1, just to introduce what is palliative care. 2, explain our treatment approach. And 3, go through the services that are provided, leaving a few time for questions. So palliative care is actually subspecialty medical care for anybody that has a serious or life-limiting condition with the focus of alleviating suffering. We work alongside your primary doctors, in this case, your cancer doctors, to provide an extra layer of support, both to you and to your family. As you can imagine, that looks different for every patient. When I see my patients for the first time, I like to say the best way I can be helpful is to get to know you, to identify what your needs are and connect you with resources that you require. Regarding our treatment approach with palliative care, we understand that disease impacts multiple domains, not limited only to the physical. So as a part of our assessment, we will intervene and treat in the emotional, social, and spiritual domains as well. You can imagine for some patients, needs only arise in one of these categories. For other patients, it may be in all 4. Over the course of your disease, needs might arrange in different of these domains for which we can provide support. One of the very common questions we get is, when can I use palliative care? A lot of people have the understanding that this is simply for end-of-life care. That's something I would like to break that myth today. We see patients from diagnosis all the way to end-of-life care. As you can imagine, for a lot of patients, that is a substantial amount of time. Palliative care is here to be that extra layer of support when and if you need it. So getting into the crux of what can we do? What services do we provide for our patients? I like to think of it in three large buckets. The first being symptom management, second being advanced communication, and third being clinical support. So you see listed here from symptom management, these are very common cases that patients are referred to us, spanning the gamut from pain, constipation, nausea, anxiety, all the way to minor symptoms we might see as hot flashes and rashes. From a communication standpoint, one of the substantial work we do with our patients is medical decision-making. We approach this with a focus of using what objective information do we have? How can we unify that with your own personal beliefs and values in order to create a treatment plan moving forward? Once that's been established, another area we can support is something called advanced care planning. How can we think ahead of what we anticipate your needs might be and solidify that information to effectively communicate it to your doctors and your teams, often in times of crisis? And finally, the care coordination piece. As I mentioned earlier, we work alongside your cancer doctors. Needs develop, we are able to kind of support and align with you as you progress through your disease. From a supportive stand care point, we often focus on optimizing quality of life. As you can imagine, that looks different for each patient. Additionally, family and caregiver support. And finally, those emotional and spiritual interventions as needed. As I've mentioned, with disease progression, oftentimes your needs will develop. So too does our approach to your care. We often kind of think of this as a ladder approach. Oftentimes patients are referred to us at the very beginning because of a bothersome symptom. From there, we evaluate what's important to you, what are your goals, and what are you hoping to achieve from your treatment and care? How can we codify this into a plan that is easily communicated and integrated into the cancer care that you're receiving? This is not always linear. Sometimes we have to go back to the beginning. As needs develop, we will be there to support you through that process. And unfortunately, if we get to the stage of terminal cancer progression where we are facing end-of-life care, that is something our team can be there to support you through. Oftentimes focusing on legacy work, the life review with a focus of producing a product that can be enjoyed, respected by the loved ones that will remain. Additionally, we provide anticipatory guidance. A lot of people have questions, what to expect as I enter the dying process. And finally, with care transitions, some patients elect that I would rather transition to a comfort-focused approach. And how can I support and transition to something other than what I'm receiving, in which case might be hospice care. All of that to say, I would encourage you to think of palliative care as that extra layer of support for you and your family. We are here. We attend to those needs as those needs develop, working alongside your doctors to provide the excellent level of care that you and your loved ones deserve. With that said, I'm happy to take any questions if they're available.
Any questions? I'll just say it's really been eye-opening for me too to understand the role of Dr. Gibbons in palliative care and moving his intervention earlier and earlier for patients, not just the last slides there at the end. It's really his ability to help and support our patients has been phenomenal. And we're blessed because he's spent some time directly in our clinic as well too. So yes, please.
I understand palliative care in the inpatient arena. how does it transition to the outpatient arena? Is it the home healthcare services that provide it?
Yeah, that's an excellent question. So the question was, how does palliative care differ from the inpatient setting to the outpatient setting? Specifically asking about home health services, that is different from palliative care. From the outpatient setting, we largely are focused on the medication management of symptom-based concerns, as well as those communicative aspects that we talked about. How do we focus on solidifying our goals of care and how that translates to the treatment plan moving forward? Additionally, caregiver support is something that we often see in the clinic or outpatient setting, as the caregivers and family members are seeing the patients outside of the hospital, and oftentimes that support is something that they focus on. That's something that my team helps with as well. Yeah, so that question was, the patients would have to come into the clinic. One of the advantages of having a global pandemic is it has increased our reach with telemedicine. So a lot of my appointments actually can be conducted over telehealth, as long as both myself and the patient are in the state of Washington. That is the one requirement.
One of the things about telemedicine too is that, you know, family members, friends from anywhere can join on it too. So.
Absolutely.
Just from a caregiver perspective, one of the things that palliative care is a new term. So palliative care to caregivers sometimes is very misconstrued. And the first time you hear the word, you think of it as hospice. So just, I know you guys have a challenge moving forwards to educate all of us that you're there as that in-between stage and to get the word out correctly so that we're not afraid to come to you.
I would just like to say I did not plant that, but thank you so much. Yes. As Dr. Wright mentioned, we actually do have data that early intervention from palliative care can lead to improved outcomes for both patients and their family. I would strongly encourage you, again, just to think of us as that extra layer of support. From the time of diagnosis onward, you are eligible for palliative care.
Martha, we have a couple of quick questions, maybe one minute. So having difficulty finding specifically healthcare psychologists for patients with cancer, would you have a list of counselors in the Seattle area?
Yes, and through Fred Hutch, we actually have a robust psychology department that we often refer to as well. In addition, if those needs are not being met, or for patients that are not local to the Seattle area, we can also provide community resources as well.
That's fantastic. And are there specific cancer stages to get palliative care that are covered by insurance? So it's mostly about insurance coverage.
From an insurance perspective, I am just like any one of your doctors. You are eligible to see me at any time. All right, thank you.
Wonderful. Thank you so much, Dr. Given. So important topic. And again, such an important concept of palliative care is in conjunction with anti-cancer treatment. So it's not either or, but it's together. So talking about supportive services and how else we can help our patients. I think a significant question we got in the clinic is about nutrition. Is there anything particular about nutrition we can do to help our body fight cancer or prevent cancer? So to comment on this important question, we're very excited to have Kate Welland. Kate, thank you so much. Uland, I love it. It's Northern European, right?
Yeah.
Yes, that's wonderful. I'm Southern European, so I love the collaboration. So Kate is a research dietitian here at the Fred Hutch, assistant professor and the director of the Master of Nutrition didactic program in dietetics in Bastyr University in Kenmore, Washington. So Kate, thank you so much for being here. Thanks for all you do for our patients.
Yeah.
The floor is yours.
Me. Okay, so I have 10 minutes and a lot to say. So I'm going to move through some of these slides fairly quickly. Thank you so much for having me today. I'm really excited to be here. I really love talking to these audiences. And so the topics I'm going to cover today, very, very briefly, is just kind of like setting the stage of the influence of diet and lifestyle on cancer development. And then I'm going to
I have one slide just on nutrition considerations during treatment, because I know several of you are currently in treatment. And how many of you have seen a registered dietitian?
We're
Usually super loud,
Oh,
but
there's online, maybe like 80 online, so just.
I get to do this. Is this, no. So one slide. So has anybody seen a registered dietitian as part of their care? Okay, 3 of you. All right, yeah. So no, just a little plug now, like at the Fred Hutch, because we're all Fred Hutch now. Registered dietitian is part of supportive care, and supportive care is covered under the umbrella of Fred Hutch. So you get to see our services free of charge. We don't bill for nutrition visits, which is really fantastic and very important. So don't be shy. Schedule a visit with us. And then I've got a couple of more common popular nutrition myths that we're going to talk about, and then just a little bit on survivorship. Okay, so just to kind of jump in, I really like this this study, this slide, that really kind of points out the importance of lifestyle factors and the role in cancer progression. And so, so basically 5.2% of all cancer diagnoses in 2015 were attributed to suboptimal diet. And comparatively, we look at excess body weight, attributed about 7 to 8%. Alcohol intake is between 4 to 6%, and physical inactivity is 2 to 3%. And then these 7 dietary factors were what were flagged as being the most attributable to a cancer progression. And so I'm not going to go through all of these, but these are the 7 here. Do they get these slides? They get the recording. Okay, so you'll have access to view these slides in the future. So just 20 seconds on the role of inflammation in cancer and the relationship of diet in cancer. And it's really that role, that cross section. We know that one of the hallmarks of cancer progression is chronic low-grade inflammation. And that's really where diet and cancer intersect, is at this arena of inflammation. And so it's a factor that can help reduce your risk. It can help reduce a risk of reoccurrence as well. And so kind of on the bookends of cancer with prevention and survivorship, we can think of how can we mitigate some inflammation in our bodies. And so, and then there's things like inflammation can damage our DNA. And I'm so sorry, I won't get to go into the details of these. It increases cell proliferation, right? So like just kind of when your cell cycle goes haywire and just keeps replicating, it inhibits apoptosis and increases angiogenesis, which is new blood cell growth. And so things that we can do, lifestyle factors such as the things that we eat, the foods that we eat can help mitigate chronic low-grade inflammation, moving our bodies, which is not something I'm going to address too much here today, but just making sure we decrease the amount of time that we're sedentary in our lives, also can contribute to decreased inflammation in our bodies. Okay, my favorite thing to talk about is fiber. And fiber is one of the key elements in keeping chronic inflammation low in our bodies. And here's several ways that fiber helps to mitigate inflammation. One of the things, if you focus on fiber, then all the other things kind of fall into place. Where do we get fiber from? Plants. Plants are the only source of fiber that we have in our diet, and whole food forms of plants, right? Some of the processing techniques that we do remove the fiber from our diets, concentrate sugar, right? So that's why we want to try to think about how do we eat the most whole food forms of food that we can so that we ensure that we get that fiber. Fiber helps to feed our gut bacteria. We're learning so much all the time about the role of the gut microbiota in keeping inflammatory markers low in our bodies. And one of the best ways to help support a healthy, diverse gut microbiota is to eat fiber, to eat whole foods. Okay, alcohol. Alcohol is a known risk factor for developing cancer. We're hearing more and more every day about the implications of alcohol consumption and rates of chronic disease, cancer being included in that. And so really the goal here is to consume as little amounts of alcohol as possible. Dietary fat. So one thing that I want to focus on when we think about inflammation, right? We kind of have that theme that we're moving through the talk with, is we want to consume healthy fats. What does that mean? Well, we need to consume omega-3 fatty acids. Omega-3 fatty acids also help mitigate inflammation in our bodies. And we don't make that type of fat, so it has to come from our diets. One of the best sources of omega-3 fatty acids are cold water fresh fish. So think of salmon, tuna, mackerel, sardines. Plant-based sources of omega-3 fats are walnuts, pumpkin seeds, flax seeds are also really good sources of omega-3 fats. And really trying to think about frequency, so 2 to 3 times a week, these omega-3 fats just need to show up in our diets. If we don't consume as many omega-3s to omega-6s, then we increase inflammation in our bodies. All right, red and processed meat. Oh my gosh, I have 1 minute left. Okay, so what I'm gonna do is move through this slide and just give you the recommendation. So the American Institute for Cancer Research is a fantastic evidence-based resource that I highly recommend all of you to become familiar with. The AICR recommends 12 to 18 ounces of cooked weight. That's about 3 ounces. 3-ounce portion is about the size of a deck of cards. You get 4 to 6 of those a week. And that's not gonna increase your risk if you're consuming that amount. And then processed meats, so think of salami, deli meats, hot dogs. Those those are a known carcinogen, and the American Heart Association encourages you to consume less than 5 ounces a day, and the AICR doesn't have a recommendation. They just want you to eat as little as possible. And then focusing on a plant-based diet to help decrease inflammation. I love this slide because we want you to eat the rainbow of color. So not only are you getting fiber when you're eating a plant-based diet, you're getting all these phytonutrients that, again, help support keeping the inflammation low in our bodies. Most of the phytochemicals that we've studied have some impact on our inflammatory system, immune system, to help keep inflammation low in our bodies. All right, so some things to think about if you're in treatment right now is to think about the amount of protein that you consume every day. This can be really tricky for patients to consume enough protein to support their metabolic needs right now. And so one thing to think about is make sure that every time you have some food, you have something that has protein in it. And then another thing, if you're experiencing lack of appetite, or you have this early fullness, you eat a couple bites and you get really full, is to spread out your meals to 4 to 6 small meals a day. And then for caregivers, I always like to talk about, if your loved one is not interested in food, has that early fullness, is to switch out the big plates for little plates. Small bowls, small plates. The visual effect on food can really make a difference. The smaller portion you provide to your loved one, the more likely they're going to want to consume it. And make every bite count. Make sure you're getting all those calories and protein needs in all the bites of food, especially if you're experiencing low appetite. All right, the ketogenic diet. I'm going to do this. 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 I'm going super fast because I'm like at my time. So ketogenic diet has very little evidence behind it to support, especially if you're in treatment, it can be very risky. There's a lot of side effects ongoing for people that are adhering to a ketogenic diet. And it's really kind of circles back to this idea that sugar feeds cancer, which leads me to this other, I'm going to skip over intermittent fasting. This other really, really common myth that I talk about all the time with my patients is that does sugar feed cancer? And right, so if we follow a ketogenic diet, then we can starve the cancer. And what we can say about that is that, again, is not the whole picture. The cancer sugar connection really is about weight and insulin resistance. And it's not about starving the cancer. Every cell in your body needs glucose, irregardless of it's a tumor cell or a healthy cell. You removing all the sugar from your diet is not physiologically safe for any person to do. If your blood sugar gets too low, you wind up in a coma. And the other thing that's really tricky that's very rarely talked about is that when you do go on a ketogenic diet and you do remove all that sugar, what happens is your body starts to break down your protein to meet the needs of your metabolic demands. And so not only are you not supporting your healthy cells, you're also breaking down more protein. And so you're impacting your overall lean body muscle mass. So these are the recommendations for survivorship. And then I want to end with a plug to Cook for Your Life. It's a Fred Hutch owned website that I've spent a lot of time working on. And it is a lovely website, no matter if you're in prevention, in treatment, or survivorship. And we provide healthy recipes for all along the cancer journey, and myth busting, lots of articles for you to check out. And then here is a picture of one of the recipes. And that's my. Okay. Thank you for your attention. I'm sorry.
Thank you so much.
Yeah.
I'm going to call you after this to get recommendation myself. I need to lose weight. You know what we can do? We can go back on your recommendations and we can ask you a couple of questions and our friends here can see your recommendations. Perfect.
Yeah.
So Dr. Wright, any questions from the chat? Okay.
Yeah, I know. Salmon versus wild caught salmon. Yeah. Whew. Yeah. So those are really good questions. And right now there's not enough evidence to support one or the other. There is some evidence that wild caught salmon is going to have a higher proportion of omega-3 fatty acids. But I would say it's along the lines of like having that organic versus non-organic conversation. I want people to be consuming these foods versus not. And if it's more affordable to be choosing farm raised or over wild caught, then that's okay to make that choice. And you shouldn't carry around any guilt around that. Does that make sense? Yeah. Okay. Yes. Yeah. As long as you're not immunosuppressed. Yes. Is raw fish okay? Yeah. Which most people that are on going through bladder cancer treatment are not immunosuppressed. And so, yeah. A whole foods, plant-focused diet, high fiber. Yes. Mostly plants most of the time. Yeah, Mediterranean diet is one of the most well-studied. And so that has a lot more research behind it, but it supports that kind of plant-focused diet. Yeah, so if that's what you like, then absolutely. But, kind of the idea to think about, like, if you think about a plate of food, think about 2/3 of that plate should be plant foods. 1/3 or less should be animal foods. So you're kind of flipping that kind of classic American plate where meat took up most of the plate. Now we want plants to take up most of that plate. So in terms of diet, right? How do you get your plate to look like that? And then the other piece to think about is like, how do you eat all the colors in the color wheel within a day's worth of eating?
Couple of questions from the chat here.
Sure.
And reminder, we'll be able to see the slides. You can go and watch it later and pause it along the way too, to get some of the extra info in there. Recommendations on juicing, and can you comment on the importance of consuming organically grown food?
Juicing. So my comment on juicing is that I want you to eat the fiber. So if you're going to juice, add the pulp that's in that you've removed back into the juice and consume that. Also, when you're thinking about juicing, when we think about eating food in general, we really want that balance of carbohydrates, fat, and protein. So if you're going to be juicing, add a little bit of fat and protein with that juice to help slow down the rate and the amount of the sugar that you're going to be consuming. So just eating the whole food is much better than juicing, and less time and work. And then in terms of organic versus non-organic, kind of goes back to the idea of that. Do we eat farm-raised salmon versus wild caught? And it's really, again, there's no evidence to date, March 18th, 2023, that supports consuming organic diets over non-organic diets. The goal is to get more plants into our diets more regularly, right? So thinking about 4 to 6 days of the week, how can you fill your plate with two-thirds of your plate with plant foods? Like 50 weeks out of the year.
Kate, very quick.
Yeah, sorry.
So are you going to get the same benefits of fruits and vegetables? I know you.
Yes. Yes. Yeah, and you can.
Can you repeat the question?
Yeah, so the question was, if you are immunosuppressed, are you still going to get the same nutrition out of cooking your fruits and vegetables? And my response, because I know we're really short on time, is to like schedule an appointment with the registered dietitian. We can go through all of those things, but quickly, you can still eat raw fruits and vegetables on an immunosuppressed diet. You just have to wash them really good. Yeah. Yes. And not by pre-cut at the store. That's also very important if you're on an immunosuppressed diet. Like, don't buy anything that's pre-cut.
So if sugar is the enemy.
It's not the enemy. No, we got to reframe our thinking. It's not the enemy. It's a critical, like, macronutrient in our diet. Like, our bodies preferentially use sugar to meet our metabolic needs.
Sugar is the same.
Yes. Yes, which is why I really promote fiber. I promote fiber. And then when we go back to that juicing question, it's really about the concentration. So when you process food, you remove the fiber and you concentrate the sugar. So that's the difference, is like sugar itself is not the enemy. It's how we consume it. We consume it in its simplest form without fat or protein or fiber. We're going to absorb that really, really fast. And all of it is going to get into our bodies. And doing that day after day after day, decade after decade, that's what leads to problems. That's what leads to insulin resistance. You pair that sugar with fat, healthy, like fat, protein, fiber, you slow down the rate and the amount of sugar that you absorb. Therefore, you don't get these sugar spikes. Fiber is your new best friend. Okay.
Thank you so much. Kate, I'm going to put your slides one more time here for picture taking. Thank you so much for being here. And that was great. Thank you so much. I'll call you for my own diet. Thank you so much. Great topic and great discussion. So moving along here, we have plenty of good content and material. So think about, again, supportive care services, how we can support you as a patient, the family, in different ways and angles. We have what we call integrative medicine. And integrative medicine, when you think about it, it has to do with a comprehensive approach in patient care that takes into account multiple components, including nutrition. And we can hear more about that from Zachary Cadro. Zachary is a naturopathic physician here at the Fred Hutch Cancer Center, and he's a teaching associate in the Division of Medical Oncology in UW Medicine. Zachary, thank you for being here, and thanks for all the work you're doing with Dr. Wakely.
Thank you.
The floor is yours.
Good morning, everybody. It's so nice to be here with you, and great to hear the lively discussion about nutrition and the great information from Kate and about palliative care. So yeah, look forward to sharing a little bit about integrative medicine with you this morning. Today, we're going to talk about integrative oncology. So integrative medicine within the field of oncology is often referred to as integrative oncology. We'll talk about some therapies and modalities that we use, some patterns of complementary and integrative and alternative medicine use in the United States. We'll talk about some clinical practice guidelines that we use, and also talk about the integrative medicine program here at Fred Hutch. Integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and lifestyle modifications. And we aim to optimize health, quality of life, and clinical outcomes, and to empower people to prevent cancer and become active participants before, during, and beyond their cancer treatment. Integrative oncology utilizes 3 categories: lifestyle, which includes nutrition and physical activity. The second category is mind and body practices, and the third category is natural products. Under lifestyle, we have diet and nutrition and also exercise. And as Kate referred to, there are some great guidelines from the American Institute for Cancer Research and also the American Cancer Society. So we often talk to patients about these. And if we identify acute nutritional needs or a lot of a role for nutrition with the patient, then we will refer them to the medical nutrition therapy team so that they can work closely with somebody like Kate for their nutritional needs before, during, and after cancer treatment. For physical activity, again, we have some really nice guidelines to guide our work. People have a lot of questions about, can I exercise during treatment? Is it going to help me? And so we talk to patients about physical activity. And then if there are certain needs that we identify in that area, we also refer patients to physical therapy and occupational therapy. Under the mind and body practices category, we have things like meditation, mindfulness, yoga, Tai Chi, Qigong. These are movement practices that combine both a mental aspect and also physical movement aspect together. Some of the procedures that we use are acupuncture, which involves the insertion of little tiny needles, and then also acupressure, which can be performed on yourself, just with your thumb and using some specific points on your body to help manage some of the side effects of treatments, things like fatigue, nausea, pain, and those kinds of things. And also there are expressive therapies, and those would be things like art and music, or sometimes journal writing. And then the third category is natural products. This includes things like vitamins and minerals, medicinal plants, microorganisms like probiotics, and nutrients and other supplements. We get a lot of questions about natural products for patients, and we are happy to answer your questions about these so that you can use natural products safely throughout the course of your treatment, or withhold certain products that may interfere with your treatments. Some data from the National Health Interview Survey from 2012 looked at some patterns of complementary and alternative medicine use in the United States. And what we know is about 80% of cancer survivors are using at least one or more of these complementary or alternative modalities. Most commonly, it's vitamins and minerals, but also herbs and other kinds of mind and body therapies and manipulative body-based therapies. So complementary and alternative medicine use and some potential concerns. So again, about 80% of people are using some form of complementary and alternative medicine. There's a variety of reasons for use. Some of those include stress, anxiety, pain, other side effects of treatment. And we just want to make sure that patients are using these safely, because there can be interactions with surgery and chemotherapy and radiation. And so it's just important to talk with your providers about what you're doing. And you can also come and see us, and we can look at the different things you're either already doing or interested in doing, and make sure that you're using those safely. The Society for Integrative Oncology is the largest multidisciplinary professional organization for our field. And there have been several guidelines that have been published about the evidence for the use of these therapies in oncology. So we refer to those guidelines, and there are more in the works all the time. So for example, the Society for Integrative Oncology and the American Society for Clinical Oncology recently published some guidelines for the use of integrative medicine for pain. And one of the highlights here is that for general cancer pain or musculoskeletal pain, there is a moderate strength of or intermediate quality evidence right now for the use of acupuncture. So that's pretty good. It's a developing field, and certainly if you're looking for non-pharmacologic options to help manage your pain, then acupuncture can be a good option. This is just a slide that's an example of some of the guidelines that were published for patients with breast cancer, but there can be some crossover here. So for anxiety and stress, things like meditation and yoga and stress management can be helpful. If you're feeling some depression or mood changes, again, meditation and yoga, relaxation, massage can be helpful. If there's chemotherapy-induced nausea and vomiting, acupressure and acupuncture can also be helpful. Our integrative medicine clinical team is led by Dr. Greenlee. Jonathan Simon, Dr. Simon is an acupuncturist. Myself, I'm a naturopathic physician. Susanna Myers is our nurse practitioner. Heidi Stetcher is our clinical nurse coordinator. And we also have 4 doctors of acupuncture on our team. So Dr. Simon, Dr. Veliver, Dr. Romeo, and Dr. Taramina. We are housed within the division of supportive care. So you've been hearing a little bit about supportive care, and there are a lot of supportive care services at Fred Hutch, and we often will help to connect patients with those various services. So you can see in here, palliative medicine, psychiatry, social work, spiritual health. We also work closely with our pharmacy team to screen dietary supplements for interactions with treatment, and then communicate back about those. Integrative medicine program at Fred Hutch, we support patients during and after conventional treatment, throughout survivorship, and near the end of life. We focus on symptom management and quality of life. So things like pain, fatigue, anxiety, depression, stress, nausea, sleep problems. Referrals are welcome at any point along the treatment and survivorship pathways. And we have resources available for patients and their families and Fred Hutch staff. We also provide a platform for patient-centered research. Okay, how am I doing on time here? Let's see. Okay, I'm getting right to the end, so let me cruise along here. Again, the goals are to improve quality of life, patient resiliency, using evidence-based guidelines. Our emphasis is on the mind and body therapies, the lifestyle counseling, and dietary supplement counseling. And the integrative medicine consultation, we'll do a holistic assessment of the health. We'll identify what your goals are, what your symptoms are, and develop an integrative treatment plan, and then provide you with some education, some resources, coordinate referrals as appropriate with other services, and provide follow-up, and then communicate with referring providers. there is insurance coverage for the consultation. So I won't get into the weeds here about this, but basically, if you're interested in an integrative medicine referral, our patient financial services will find out what your insurance will cover, and then they'll let you know what the coverage is before. So there is coverage for the nurse practitioner, basically from any kind of insurance. So you can have a consultation with the nurse practitioner for integrative medicine. And then for acupuncture, there is some coverage. So if you're interested, just let us know and we can figure that out. So, and as Kate mentioned, Cook for Your Life website is a great resource. I know Kate's written some great articles on there. So there's recipes, articles about fiber, cancer fighting foods, and all of this. So I would encourage you to check that out. And then there's currently some funded research in our program. One that is relevant to all of you would be the or to potentially to some of you is the acupuncture to decrease BCG related adverse events in bladder cancer. So if you're interested in that, just let us know. So here's some contact information and additional resources and some key takeaways. I know we're short on time, so I'll just cruise through that. And thank you very much for your time and having me here today. Yeah, that's great. Good idea.
What is the biggest barrier for getting the insurance coverage? You know, you showed that slide with like Medicare, yes, Medicaid, no. Is it more trials like we're doing to show clinical benefit?
Yeah, I think that's excellent. So in Washington State, there's really good coverage for integrative medicine services. So most of the commercial insurance plans will offer most of the commercial insurance providers will offer one plan that does cover integrative services like naturopathic physician or acupuncture. And the state Medicaid also covers naturopathic physicians and some acupuncture. And in terms of Medicare, which is the national program, still a lot of work to do there. So naturopathic physicians are not covered yet by Medicare, but there's a lot of lobbying work that's happening. Naturopathic physicians are starting to get covered by the VA. So there's progress there. And I would say, yeah, with acupuncture, Medicare covers low back pain. So chronic low back pain, I think it's approved for that. And so, yes, certainly as we get more research and more lobbying to show that patients and physicians are interested in using these therapies and that they're effective, we will keep working on the coverage. So, yeah, thank you.
Any other questions?
One of the key takeaways I took just in reading your synopsis is neuropathy. Neuropathy is very big in all cancer aftermath treatments.
Yes.
And how does naturopathic work with neuropathy?
Yeah, that's such a great question. So there's a few trials that show cryotherapy, which is the use of a cold application to the hands and feet during treatment may help. So there's some preliminary evidence there. So that's kind of on the prevention side. And then for treatment, actually acupuncture, there are a few trials that show acupuncture can be effective in patients who have neuropathy. So we often use acupuncture. And then also in physical therapy, there's something called low-level laser therapy that's often used to kind of try and help promote some healing in the cells. And yeah, so that's what we use. There are some pharmaceutical drugs that are also used for neuropathy, but a lot of work happening in that area. There's been tons of natural products that have been tested for that. We're still, working in that area. So none yet that are routinely used, but working on it. Yeah.
Are you currently doing that?
Great question. Yes, I think there is one for acupuncture. I'll have to check on that, but yeah. Awesome. Okay, thank you so much. Yep.
I think one of the neat things from a clinical perspective is how all of these teams working together and bringing their, expertise and skills together to help the patient. So, and if your docs aren't bringing it up, myself guilty too, just ask, Next, we have Dr. Jay Liao. So Jay Liao is in the Department of Radiation Oncology. He's an associate professor and he's been a fantastic colleague. One of the things, obviously, I'm a surgeon, I cut out the tumors, but one of the things we really worked for over the years, and one of the reasons we set up our multi-specialty bladder cancer clinic for those with muscle invasive disease, was to try to do more bladder preservation and to have radiation be an option. So we continue to grow that, and I'm excited to hear Jay talk today. So thanks.
Good morning. It's so nice to see people in person. I'm Jay Lee. I'm one of the radiation oncologists here with UW Fred Hutch. I've been with the team here for about 15 years or so, and it's been inspiring to work with such dedicated folks and to see the advances we've made in bladder cancer. I'll jump right in. We'll review today the topic that's really of interest to us, which is preserving the bladder in patients with muscle invasive bladder cancer. And it's a topic of great interest to our patients and to us as well that are dedicated to this field. We'll talk a bit about the role for radiation and for chemoradiation for bladder preservation, review some of the treatment approaches we use in radiation oncology and some of the technologies that we use. A little bit of just a brief mention of research and future directions in this work. Briefly, there's an important distinction between muscle invasive and non-muscle invasive bladder cancer, as you've heard. And muscle invasive bladder cancer requires more invasive measures in order to treat and to cure. So it requires much bigger surgery and much bigger treatment in order to treat effectively. And the cornerstone of treatment has been treatment with our surgeons, which involves a very large procedure with removing the bladder. It's a radical cystectomy. It's a very complex operation, and we're lucky to have the skill of our surgeons like Dr. Wright in doing such advanced procedures. Oh, sure. And with this, there's a very high rate of cancer control in the pelvis, but there's big quality of life considerations with losing the bladder, and certainly a lot of surgical risk to consider with such a large procedure. And how about those that are not healthy enough to undergo surgery? This applies to many patients that we see. So we asked the question, is organ preservation possible to treat the cancer effectively and preserve the bladder? And this is something that we looked at with this approach in many other cancers. So we do this in head and neck cancer, and treating cancer of the voice, box, and the tongue. This has been a strategy and is a standard for prostate cancer, anal cancer, many other cancers. Where do we stand with bladder cancer? Well, like many advances in medicine, this is something we stumbled down a little bit by accident. And there were studies in Europe that looked at actually patients that were undergoing cystectomy, but before cystectomy, they had preoperative radiation chemotherapy. And we found that there was actually a subset of patients that had a complete response by the time they had surgeries. There was no residual cancer. So this led to the thought that maybe we can use this as the primary treatment and avoid surgery, so using primary radiation and chemotherapy. So this pathway of treatment developed, which we call trimodality therapy, and it's called trimodality because it still involves our surgeons first doing this initial scraping and removal. It's a maximal scraping called TURBT, and then you follow with the radiation and the chemotherapy, which is the second and third parts of the treatment. This is typically a treatment given over about 4 to 6 weeks of daily radiation. And then there's also chemotherapy that's given at low dose to help sensitize to the effects of the radiation that's given once a week. We used to interrupt the treatment about halfway, 2/3 of the way through, and do biopsies to make sure the treatment was working and stop the treatment if it wasn't. But nowadays, we found that there's pretty equivalent outcomes of doing the treatment continuously and then following afterwards with close surveillance. In patients that are non-responders that have persistent invasive cancer, then salvage surgery or cystectomy then as a fallback. But we found that there was a pretty high rate of complete response with this approach. This is some of the early data that was compiled in about 500 patients over numerous trials, including some work by cooperative groups as well as Harvard Hospital and others. About 500 patients, and you'll see here that the complete response rate was pretty decent. It was in about the 70% range. About 1/3 of patients, though, still required salvage cystectomy just because of lack of response or persistent cancer. And importantly, when you leave the bladder intact, there's still a risk of having cancer that's persistent or recurrent in the bladder. So about 15% of patients may have muscle invasive recurrence that may still require cystectomy as the best approach. But about 1/3 of patients have non-muscle invasive recurrence, and that may be cancer that may still be dealt with bladder conserving approaches. And importantly, we still need to make a dent on reducing the risk of distant spread of cancer. And that's been a challenge both with surgically managed patients and with chemoradiation. We've gotten better over time. So this slide just shows that from the 80s to 90s to the more modern era that our complete response rates have gone into the high 80% range, both a testament to better patient selection, but also I think improvements in treatment technique over this era. And then the rates of salvage cystectomy have dropped from the 30–40% range now to about 15% or so. Of course, there's side effects to this treatment, and these are some of the expectations. There's urinary kind of irritative effects, a little bit kind of like a urinary tract infection, what it feels like. So frequent urgent urinations and burning with urination during the treatment course that then takes some time to resolve afterwards. And many patients experience some bowel effects, so loose stools, diarrhea, and then there's effects of the concurrent chemotherapy administration that can cause some fatigue, nausea, low blood counts. So does this work? Well, fortunately, the quality of life studies in patients have shown pretty good bladder function in the long term in the vast majority of patients, and the majority report satisfactory long-term bladder function. There's ongoing work from many, including like Dr. Gore with our team, that's closely examining how this compares with surgically managed patients with a cystectomy versus chemoradiation. So this is something that there's a lot of ongoing work with examining closely. What we learned from this is that careful patient selection is really important, and not everybody does well with this approach. So we want to select the patients that do the best with eradicating the cancer and with good outcomes. And these are patients with small tumors that can be really cleared out well by the surgeons before us doing the radiation and chemotherapy, ideally normal urinary tract drainage, and also cancer that's just in the solitary spot and with very limited evidence of any precancerous spots. And importantly, long-term surveillance is important because we want to catch recurrences early that we can still salvage effectively, ideally with bladder conserving approaches still. And importantly, radiation does have a role in many patients that don't quite fit these criteria. A lot of patients that we see may have other health issues that may lead to them being not ideal candidates for big cystectomy procedure, or just a matter of age or other health issues. What if this doesn't work? Well, salvage cystectomy is possible in the back end, but it's definitely more complicated, definitely has added risks, and there definitely can be some trade-offs as far as what the urinary reconstruction options are. And it's definitely better performed at a high volume center, but it's something that still may be feasible if the radiation chemotherapy doesn't work. Just a few slides have shown that there's been advanced in radiation technique over the years, which is very exciting. Our early treatment approaches for this were delivered with radiation fields like this, called 4-field box, which is what it sounds like, is kind of a cube-shaped radiation distribution targeting the bladder. And this is a little bit kind of what it looks like nowadays. We treat with an approach called intensity modulated radiation therapy, which uses many radiation beams coming from all directions, kind of custom tailored radiation based on CT scan anatomy and from patient to patient, with really conforming the radiation coverage specifically. We have techniques now for image guidance, which is lining up the treatment on a daily basis with onboard kind of real-time imaging that helps improve the accuracy. And then our team was involved in this work, which is using a bladder marker that injects this dissolvable marker to kind of paint the location of where the tumor is at, to help improve the radiation targeting. And we were one of the first centers in the world actually to examine this approach. So how do these stack up between cystectomy versus trying to preserve the bladder? Should we be doing it in more patients? Well, we don't actually know from a head-to-head study, unfortunately. We would have loved to have seen Manny Pacquiao and Floyd Mayweather duke it out in their prime, or the early 70s Lakers 90 Bulls, and we can place bets on who would have won. We don't know from a head-to-head randomized trial, and probably one will not be completed, which is the complexity of this. But at least reassuringly from retrospective experiences over the years and trying to match patients as well as we can, the numbers look and compare favorably in well-selected patients for chemo and radiation as far as survival outcomes compared with surgically managed patients. So how do we navigate these decisions? Well, we've structured this bladder multidisciplinary clinic that you've probably heard of, where patients are seen by urology, like our surgeons, Dr. Wright, your medical oncologists like Dr. Grivas and myself. We get input from our pathologists, from our radiologists as well. And there's important input as well from supportive care services, as well as nursing. Many of our patients may be candidates for clinical trials too. So it's an opportunity to navigate all these decisions. So it may not be quite as exciting as it is on TV, but I think we have a lot of camaraderie and we're all, very excited about the work that we do. And I think it's been a great service to our patients with seeing patients in this format. Some new directions that we're looking at that are exciting. we're trying to see if we can move the needle forward. So this is a national trial that we have open here that's looking at combined chemoradiation in patients with muscle invasive bladder cancer. And it's a randomized comparison doing that standard radiation and chemotherapy versus adding on an immunotherapy drug. That's something that's drawing from something that's used in more advanced stage cancer and has become a therapeutic standard. So we're trying to see, does this give us a better opportunity to preserve the bladder in patients earlier on with localized cancer? This study we were involved in early on a number of years or so ago is a small study looking at earlier stage cancer. So it was in patients with non-muscle invasive cancer to see, can we preserve the bladder in those patients where the next step may be cystectomy because they've had intravesical therapy, BCG hasn't worked, and we're trying to avoid cystectomy or delay cystectomy. This study was actually just reported a year and a half or so ago and showed close to 90% freedom from avoiding a cystectomy. So I think added work in this area is really fruitful. Some new directions just in 2023 here at UW-Fred Hutch. We're beginning to look at artificial intelligence-based planning, which is very neat with this platform called Limbus AI, where basically there's computer-assisted, AI-assisted kind of radiation treatment planning with helping us to kind of outline the structures that we're targeting. And also new as of this year is this radiation platform called Variant Ethos, which allows us the ability to assess the daily anatomy in real time just before treatment, but also adapt the treatment and kind of replan it custom tailored to what it looks like each day within a short time frame of just 15 minutes with delivering the treatment each day. So there's a lot of really neat things that that we're involved in to hopefully kind of further advance our approach with this. All right, so that was trying to compress in about 10 minutes here. I'm glad to take any questions.
Fantastic, Jose. Thank you so much. Questions? I took pictures of our multidisciplinary clinic, which is my favorite clinic. I always say that because I interact with all of you and learn from you, and we provide a one-stop shop for the patients, which I think is important to patient-centered approach. Okay, so we have a good question, Jay. After recurrence, will tumor be localized in the bladder or distant tumor? I think the question is mostly about the patterns of recurrence after radiation therapy.
Question. Yeah, so there's both risk of in-bladder recurrence, which may still be curable. In-bladder recurrence, like I mentioned, about 15% is muscle invasive recurrence, which the standard would be with managing with cystectomy. About 30% risk of non-muscle invasive recurrence, which we can still preserve the bladder, which may still involve just doing TURBT procedures, intravesical therapy like BCG. Importantly, there's definitely a risk of distant spread of cancer, and that's a challenge with patients, whether they're managed with cystectomy or with radiation and chemotherapy. And that depends a little bit on stage, but it's in the range of 20 to 30% risk as far as distant spread of cancer. We're hoping that improvements in systemic therapy with chemotherapy getting better and adding immunotherapy to the picture will help kind of reduce those numbers. But those are things that we're continuing to look at.
Thank you, Jay. Great. And one other question is, any systemic side effects from radiation therapy in the bladder?
Yeah, there's definitely fatigue associated with treatment for many. Some of it's hard to separate out from effects of chemo that we administer concurrently. We try to blame all those effects on you guys, but it's definitely shared. And, you know, there's definitely just whole body effects of when you're doing treatment that's causing urinary effects, bowel effects. It's definitely something that affects your, you know, your whole being. Yeah, so we do our best to support all those things. And there's definitely supportive measures we do to help manage those effects during treatment.
And to your point, Jay, we have integrative medicine and nutrition and others, palliative care, so we can all together work as a team to help and better serve the patient. We have actually an interesting question that may actually borrow Dr. Wright's help here. Any progress with artificial bladders like transplants?
Yeah, great question. I get asked commonly. As far as an artificial bladder, it's actually, so kidney replacement, dialysis is just a filter, just runs it through. Artificial heart pump is just the pump going. The challenge of a bladder, even though it seems simple, is that it has to do three things. It has to slowly accommodate more volume under low pressure, and then stay there for an extended period of time, and then squeeze together to empty. So those are three different complex processes actually to do in a system. And from a bladder transplant, different nerves are doing those different properties within the system. So it's not as easy as just plugging in a single artery and vein and having it work. Those other aspects wouldn't work, and you end up having a very small, contracted, high-pressure bladder that won't function. So unfortunately, there's a lot of work being done, but I think we're quite a ways off before that will be available.
Won't be 3D printing any bladders anytime soon.
But the research continues, so thanks, Jonathan, excellent point. Any other question? I think we have one in the back. So the question is about AIDS and how this is in effect, tolerance of surgery versus radiation.
Great discussion. We talk about it all the time and navigate that complex decision in patients in our bladder clinic. And age is not a fixed number, because there's biologic age too. So I see 70-year-olds that run circles around me. Sometimes I treated a 70-year-old that was a competitive skier one time. And so we assess all those things, because your fitness may also be determined by other comorbidities. In general, though, yes, I think the older that you get, there's definitely greater risks of the impact of the surgery affecting your recovery, having prolonged hospital stay, other complications like cardiac complications, infection, things like that. So it definitely weighs in. Yeah, so like I said, I don't think there's a fixed number. It really is pretty individualized, I think, with this decision. Yeah.
Thank you so much.
When recurrence happens and it goes towards a kidney, do you then look at treating the kidney the same way, or does your group then look at radiation on the kidney when it's moved from the bladder to the kidney?
Good question. Yeah, it's probably pretty unique situations where we see that. There sometimes are cases where we see upper tract or like urothelial or cancer along that area. That many times becomes much more a surgical managed situation because there's less evidence for the use of radiation therapy in that scenario. And then just anatomically it becomes a little bit too extensive a volume for us to radiate with acceptable effects with radiation. Yeah. Okay. Thank you. Yeah.
So fantastic talk. Thank you, Dr. Liao. It's really exciting to work as a team and try to address different scenarios because as I always say, it's always a different scenario. Not the same cancer occurs in the patients. It's always a different cancer. And that's actually one of the challenges we have in oncology, how we can treat someone individually based on individual characteristics, based on the cancer characteristics, and of course, other factors relating to physiologic aids, other medical conditions, and of course, functionality and of course, patients' preferences as well. So in that context, in the effort to individualize therapies, we're doing plenty of research. And one of the reasons we are here, and personally I'm here because I love research and I want to keep moving the field forward. And I'm blessed to work with many amazing individuals like speakers today and many others, and of course, many mentees and also members of our research team. And I want to give a shout out to Amanda and Caleb, who are part of our research coordinators and helping us a lot with clinical trials. And I will start by saying that when we think about clinical trials, I think we have the four most important points are not in my slides. Number one, clinical trials should be offered in an equitable manner across patients, genders, ethnicities, races. It's a standard routine approach and listed in guidelines as a standard treatment, you do. So we have to think about clinical trials as a routine option for our patients. And sometimes we have a trial, sometimes we will not have a trial, but I think it's important to think about it in the treatment paradigm. Number two, everything that we have to offer to patients today, all the treatment options have been derived from clinical trials. Everything we have on the table today have been tested to see if the treatment is safe and effective. And that's why we move forward by doing more clinical trials, generate more options for our patients. So it's the vehicle of progress, as I say, it's how we make progress in the field. Number three, when someone goes on a clinical trial, it serves two purposes. Number one, which I think is important, we try to help the individual patient. So the benefit for that patient in front of us is a priority. We try to help that patient by an innovative, promising treatment, which is not standard yet, but we aim and hopefully make it standard in the near future. And we have had examples of that in our career, which is fantastic. I'll show you a couple of them. And number 4 is the trials we usually do in genitourinary oncology and bladder cancer. Most of the trials are not first in human trials, meaning these drugs have been tested in humans and people before. There's some degree of evidence of benefit, there's safety data, and then we're moving it along to what we call phase 2 and phase 3 trials. So I think this is important as kind of principles how we think about research. I have, I think, a slide of disclosures here for my research as well. And I will start, as we discussed before, I made this slide just to separate the different stages and phases of bladder cancer. And some of you may think, oh, that stage below, that's where I am. Or there's a continuum, of course, and some people may have what we call localized bladder cancer, the non-muscle invasive bladder cancer that Dr. Nyame talked about. Some may have muscle invasive bladder cancer, where the multidisciplinary clinic that Dr. Liao mentioned, and Jonathan, me and Jay, we may, and other colleagues may have this multidisciplinary clinic. And there may be situations where the cancer has spread to other organs called metastatic. So we try to have clinical trials across the spectrum of these disease stages. Now, Dr. Nyame did a great job, and we depending on the exposure or not, treatment or not to BCG, we have defined what we call settings of treatment or spaces of treatment. People who never had BCG, we call the BCG naive, or if they have BCG treatment, they're BCG experienced or exposed. And if they meet criteria that Dr. Nyame mentioned, we have BCG unresponsive, and depending on the setting, we have different clinical trials. So this different slide was covered by Dr. Nyame before, and depending again on if someone has or not received BCG, we may have different trials looking at immunotherapy. Immunotherapy, in a simple way put, is activating the immune system against the cancer, and we have different forms of immunotherapy. And of course, we have to be smart about how to combine it, right, with different partners. And an example here is that we have immunotherapy given through the vein. The immunotherapy is activating the immune system systemically, combination with intravesical BCG that Dr. Wright and colleagues give inside the bladder. And of course, we have trials like the BRIDGE trial that is intravesical treatment inside the bladder installations of BCG versus chemotherapy. And that's just examples of trials we have. Now, if we think about the neoadjuvant therapy, neoadjuvant meaning give chemotherapy before bladder comes out, before cystectomy. And that's something that is important to know, that not everybody needs that. If, for example, have not muscle invasive bladder cancer, there's not all of that. But if someone has muscle invasive bladder cancer and the body is strong enough to tolerate specific chemotherapy containing a drug called cisplatin, then we tend to give chemotherapy before surgery. This is called preoperative or neoadjuvant. And that's why our job is, as medical oncologists, and in collaboration with our colleagues, to define which are those criteria, who are those patients, which are those factors that we have to give chemotherapy before surgery. But that's something we have a discussion in the clinic about, because in appropriate situations, chemotherapy before surgery should be given and prolongs life. Now, we have plenty of clinical trials like to build upon chemotherapy, right? And we say, can we do chemotherapy plus something else? Or for patients who we think chemotherapy is not a good option, cisplatin is too much for them, can we use other therapies, for example, immunotherapies before surgery? And right now, the immunotherapy before surgery is experimental, but the early phase 2 clinical trials have been very promising. And we saw that, hey, immunotherapy might in the future have a role before the bladder comes out as a neoadjuvant perioperative therapy. Let's confirm that hypothesis by doing phase 3 trials, right? Phase 2 are smaller, lower number of patients, gives a signal, thumbs up or thumbs down, go, no go. And phase 3 are the confirmatory trials, larger sample size, larger number of patients. And then we have the ultimate test. Does it help the patients or not? And this is just a list of examples here that we have chemotherapy alone or chemotherapy plus immunotherapy, right? Does the combination help before someone goes to have the bladder removed? So these are the trials we're doing. Again, answer the question in a definitive fashion. And hopefully, a couple of years from now, we have an answer. Does immunotherapy add value when it's given with chemotherapy or by itself? before the bladder comes out as a neoadjuvant approach, preoperative approach. We also have, of course, different characteristics, different features. So the bladder cancer, the most common form is urothelial cancer. Urothelial are the cells lining up the bladder. But sometimes under the microscope, the cancer may look a little bit different. We call this variant histology, which is a little bit different than the classical run-of-the-mill type of bladder cancer, or maybe a mixed picture of urothelial, the most common type, plus some differently looking cells under the microscope. And this variant histology bladder cancer, we have questions, how do we treat that? Does it respond the same way? Do we need to develop more therapies because it's usually a more aggressive form of bladder cancer? So Dr. Wright, myself, and others, and here you see a picture of our previous fellow, Dr. Kaki, have designed and developed clinical trials addressing this unmet need. How do we treat variant histology, these different looking cancers under the microscope, in addition to the urothelial classical histology? And in that trial, we're combining chemotherapy with immunotherapy as a promising approach to deal with this bladder cancer with variant histology looking before the bladder comes out, before radical cystectomy. And Dr. Talukder, he's sitting back in that room here. He's a third-year fellow with us. He's working with us in a similar concept. Patients who cannot get chemotherapy, can they get a new form of treatment, a promising form of treatment with let's say a targeted chemotherapy to try to develop more options for our patients with variant histology bladder cancer. So if the take-home point is we're looking here across the picture, and in one size does not fit all, so we try to develop trials for patients who do not have the classical urothelial cancer diagnosis or a picture under the microscope. Very quickly, there are some indications about giving chemotherapy after surgery. This is only if chemotherapy was not used before surgery in certain occasions, and depending on the depth of the cancer invasion when the bladder comes out. When we have the cystectomy, then we look at the microscope with our pathologists and say, the risk of cancer coming back is X based on what we see under the microscope. Is there a role of giving therapy after the surgery? Again, ideally, we give the chemotherapy before. That's our ideal scenario. But there's sometimes questions about giving it after. And the other question is, how about immunotherapy, again, activating the immune system? Is there value added or not by giving immunotherapy after cystectomy, after surgery? There have been 3 clinical trials asking this particular question, and those clinical trials have very similar design. They look immunotherapy versus no immunotherapy in patients who already had the bladder removed, radical cystectomy, right? And so far, we have a trial that did not show benefit. The one in the middle, the blue line, the blue box, did not show benefit with immunotherapy after the surgery. The first one, the green, showed benefit. So that if you give immunotherapy after surgery, in certain populations, certain patients might actually reduce the chance of cancer coming back. I'll show you that in a second. And we have a tiebreaker, the pink one. We had the trial open here. We had many patients accrued. We don't have any data results yet. We are waiting for that pink box to be the tiebreaker and answer the question about value of immunotherapy afterwards. So I mentioned just a minute ago that the green box showed benefit, and this was just an example of a trial that changed practice. So patients may or not have received chemotherapy before surgery. They go to cystectomy, removal of bladder, and in that trial, the result was that the chance of cancer coming back, a recurrence, or death was reduced by immunotherapy after surgery. Of course, this doesn't apply to everybody, but based on particular characteristics, features of the cancer after the bladder is coming out. And we saw data that, of course, there can be side effects that we have to discuss with the patients, pros and cons of immunotherapy, and of course, the treatment burden, how often someone has to come in, for example, once a month. But we also saw that the quality of life of the patients was not significantly deteriorated. So the drug was well tolerated. So we look at also, again, longer life, chance of recurrence, quality of life, side effects. All of those metrics are part of clinical trials to see if we add the value in the patients. Dr. Lia already showed that important trial for patients who want to keep their bladder preservation. We have the maximal scraping, TURBT, and then we do at the same time concurrently chemotherapy and radiation. And we try to see whether the in addition of immunotherapy with this drug called atezolizumab, does it add value or not to chemotherapy and radiation? So this is another example of a trial evaluating the role of immunotherapy in this attempt to keep the bladder. We have other examples, and I'm going to close the talk soon, for patients where the cancer has spread to other organs and lymph nodes or lungs. How can we help these patients? Can we find more treatment options for them? And this is an example of a trial that has many different scenarios and different arms, as we call them. And depending on where we are in the treatment course, what we call first line with no prior treatment or subsequent treatments, we see if that trial fits the patient specifically, and we see what are the treatment options available, and do we meet all the criteria that make this trial a good option for the patient. So we try to cover different scenarios in different lines of therapy and taking into account other medical conditions and other factors. One thing I want you to also think about as we go forward in the future, we have this concept of targeted chemotherapy. So we look at targets expressed in cancer cells. HER2 is a protein expressed in the cancer cells. We can measure that protein, and there are other proteins too. And if that target is expressed in cancer cells, we now have kind of magic bullet drugs. It's an antibody targeting that target, that protein, linked with a chemotherapy. So a target chemotherapy approach that can help us deliver chemotherapy in a more specific way. So now we're doing clinical trials like the previous one and this one, trying to, again, deliver chemotherapy in a more targeted fashion, if the target is there expressed in the cancer cell. So we're trying to measure that. And that slide shows you the revolution in the field of bladder cancer and urothelial cancer in general in the last 6 to 7 years. We have many new drugs approved that we did not have before. And sometimes I talk to my patients in the clinic, I said, if I met you 7 years ago or 6 years ago, I would have a much more boring discussion. Now, because of clinical trials, I have many more options for you. And of course, we keep going with more trials. And this is just what happened the last 6 years only. And to conclude my talk, I want to also give a shout out to the value of not only prospectively done clinical trials, and I gave you some examples, but also like what Dr. Gore mentioned, we try to complement our knowledge by trying to generate data and say in a real world scenario, right? Let's look in the last 10 years and see what happened. What treatment did the patient receive? How did these patients do if they received treatment A, B, or C? Or what are the factors that were associated with a better outcome or less outcome? So to answer those questions, we have great mentees. And again, I talk about Dr. Dalukder, he's the back. Dr. Bakalud is also in the back. And with Dr. Wright together, we have this program that we mentor, of course, trainees, and we try to collect data and answer practical questions. So we have a database in collaboration with more than 25 centers in the country, and some of them are in Europe. And we have a database, a registry, and we collect data points, right? Age, gender, cancer type, what treatment the patient received, how long do they live, how well did they do with this therapy? And that way we can do statistical analysis. We have a statistician working with us, and we try to answer practical questions. Does the previous exposure to BCG has anything to do with how the cancer may respond to immunotherapy right now? Or does the time between the diagnosis and the cancer recurrence, does it have any impact in how the patients respond to treatment? So all of those questions can be answered, hopefully. We have actually published about 10 manuscripts like that to answer those practical questions. So I will leave it at that. The last thought I would say is a team effort. Nothing is done by one person. And kudos goes to the team members that help us. And of course, the patients who inspire us to do all this research. Thank you.
We have time for one question. A good one from the audience was, can you define who's not eligible for cisplatin? You have a lot of cisplatin ineligible studies up there.
Great question. And that is that's evolving over time. The criteria we have used historically come from a consensus, like an agreement-based. There was a manuscript published by Dr. Galsky, who is in Mount Sinai, and other colleagues. And we sat together, the experts treating bladder cancer, we said, which factors can make us not comfortable giving cisplatin? And the factors that came up have been, number one, the performance status of a patient, what we call the functional status, right? If someone is like up and about running and doing stuff, it's a good thing, right? If someone is in the bed confined, doesn't move much, that's makes it worried about complications. We also look about kidney function, and we can measure kidney function by measuring the creatinine in the blood. We talk about hearing because cisplatin can affect the hearing function. So hearing function assessment can be relevant. If the patient has neuropathy, you asked this before about neuropathy and how severe the grade of neuropathy, and also if there is any significant cardiac problem like heart failure or things like that. These are factors that we take into account, and some other factors as well. Any other quick questions? I know I had a lot of data. Yes. A great question. So the question is about subtotal or partial cystectomy. I will quickly comment. I will ask Dr. Wright to comment too, because he's the expert. We rarely, almost never do partial cystectomy. Usually it's a radical cystectomy. There are some specific occasions when there is a tick in the bladder called diverticulum, or there is a rare cancer types like a urachal carcinoma, very unique scenarios where partial cystectomy may be considered. But for the vast majority of patients, we do not recommend. Jonathan, any comments you have on that?
Very well selected, carefully selected patients, it's an option, but in general, because of the field effect, it's leaned against. So,
patient selection as always.
I think we.
Awesome, very good. So, talking about research, and I know this was a lot of information, just to give you a flavor of what we try to do in clinical research, but it's a collaboration, of course, with the scientists who work endlessly in the laboratory. It's in interface interaction, interplay between the clinical researchers like me and people who do amazing practice changing research in the laboratory. And one of those people is Dr. John Lee. John is an assistant professor here at the Fairhats, and he's one of those brilliant people that every time I talk to, I get smarter. So John will talk about preclinical developments, laboratory research in bladder cancer. Thank you, John.
Thanks a lot. This is really an exciting opportunity to talk to you a little bit about some of the research that's ongoing in our lab. And just to give you a little bit of context, prior to the initiation of clinical trials where we're investigating many of these new agents, there's many years of research that has to occur in the lab to ensure that these new treatments are effective and safe before we can actually put them into first-in-human trials in patients. And so I'm going to share with you two different types of treatments, one of which has been mentioned previously, antibody-drug conjugates, which are really exploding in the field of cancer. And then the second is an even newer technology called chimeric antigen receptor T-cell therapy. And we're really excited about the developments in both of these fields, and hopefully we can get these into clinical trials in the next few years. So I'll first talk about antibody-drug conjugates, and you can see this cartoon on the right. This is what an antibody looks like structurally, and the drug conjugate requires a linker that then connects to the antibody, a very potent type of chemotherapy, oftentimes called a payload. And so already discussed has been the potential advantages in that you could then concentrate this potent chemotherapy at the target, at the cancer, in a more concentrated manner and targeted manner, because you're using the ability of the antibody to very specifically identify the tumor. And so antibodies are actually naturally produced in our bodies, right? Many of us have received COVID vaccinations, and really the idea behind the vaccination is for our body to produce antibodies to neutralize COVID-19. And so we can also produce antibodies in the laboratory with very exquisite sensitivity and selectivity against any target that's present on the surface of a cancer cell. And so the additional advantages are that we can increase the amount of chemotherapy that we deliver. When we deliver chemotherapy intravenously without this type of targeting mechanism, oftentimes we're limited by the toxicities. Here, because we're able to deliver it directly to the tumor and potentially not to other sites in the body, we can enhance the delivery of cytotoxic chemotherapy. And all of this results in what we call an enhanced therapeutic window, which means that we can get more anti-tumor efficacy while sparing normal tissues and therefore increasing the overall level of safety. As I mentioned, this has really exploded. There are a total of 15 antibody-drug conjugates that have been FDA approved to date. And in fact, 2 of them are already approved for advanced urothelial carcinoma. One is called Padcev, which targets a protein called Nectin-4. And then the other is Trodelvy, which targets a protein called TROP2. And then certainly there are others that are in clinical trials, as Dr. Grivas has just mentioned. So how do ADCs or antibody drug conjugates work to fight cancer? So when these antibody drug conjugates are administered into the veins, they actually can circulate in three forms. So they can circulate in that entire reconstituted form in which there's an antibody, the linker, and the drug. Some of the product may actually just be the antibody itself, and some of the product may just be the payload. And so that's actually potentially beneficial in that you may get multiple mechanisms of action against the tumor targets. So these antibody drug conjugates will circulate throughout the bloodstream, and then they'll slowly diffuse out of the bloodstream into tissue sites and come into contact with various tissues, including tumor. And then subsequently, what can happen is that the antibody itself binding to the target can cause various mechanisms of immune-mediated cell death of the tumors, or the antibody drug conjugate itself can be taken up into the cells after it binds the tumor cell. And once it's inside of the cell then breaks up the components of the antibody drug conjugate, releasing this potent chemotherapy to actually kill the cells. And interestingly enough, some of these payloads can also have effects on neighboring cells. So it may kill that cell that took up this antibody drug conjugate. The payload will kill that cell, and then the payload can actually be taken up by neighboring cells in that neighborhood and then kill those cells as well. And so that's considered to be what's called the bystander effect. So we do have a program in the laboratory where we're trying to develop new antibody drug conjugates. And so this is some data that's pretty advanced now in the laboratory against a new target in bladder cancer. And one of the first things that we did was we wanted to determine how often is this target expressed in bladder cancer models. And so what I'm showing here on the left is a bar plot indicating the amount of this target that's expressed in bladder cancer cell lines and prostate cancer cell lines. And what we can appreciate is that pretty much all of bladder cancer cell lines express a very high level of this target, whereas if you look at prostate cancer, only about a third of those cells or cell lines express this target. And so we've gone ahead and focused specifically on developing this for bladder cancer. And this is some additional data. It's a little bit complicated, so I'm not going to go through all of it, but essentially we took a cell line in which we know that the target is expressed, and then we engineered that cell line to remove the target. And really, this is a way to actually determine the specificity of this antibody drug conjugate. And so if you look at the blue bar on the top, or the blue line, that's the killing activity of the antibody drug conjugate when the target is present. And when we remove the target in the cell line, that killing activity is shifted significantly to the right, meaning that these cells are spared when we treat with the antibody drug conjugate. So what this really means is that the shift in the blue line indicates that this antibody drug conjugate is very specific to the target. And so we've moved on and performed studies in mice. This is usually one of the last sets of studies that we consider before we consider taking this into the clinic. And so we use this CoCab1 tumor model, which is actually developed by colleagues and researchers here at Fred Hutch and University of Washington, implanted these into mice and measured the tumor volumes after treatment with just a control or PBS, which is saline, or increasing doses of this antibody drug conjugate. And what you can see is that we treated a couple times over the course of about 3 weeks. And at a dose of 7.5 milligrams per kilogram and 15 milligrams per kilogram, we see a real significant dose-dependent inhibition of the growth of these tumors. And at 15 milligrams per kilogram, even about 60 days out, we see that there's very minimal tumor activity. So we're very excited about this, and we're testing this in additional mouse models, but we're very hopeful that this will make it into the clinic within the next couple of years. So I want to switch gears now and talk about chimeric antigen receptor T-cell therapy. This is another significant interest in my lab. As many of you may have heard over the last decade, this has been really one of the revolutionary technologies in cancer therapy. And so the idea behind it is that we have professional immune cells in the bodies called T cells, which are endowed with very potent killing activity. And so it's possible to actually take a patient, remove these immune cells, and reprogram them in a way that they're very specific to the identification of a target that they're activated when they engage the target, and then they leverage that killing activity to really to kill the target cells or the tumor cells. And so currently 6 of these CAR T-cell therapies are clinical approved for hematologic malignancies. And in fact, many of the first patients who were pediatric patients with leukemias who faced terminal diagnoses, there were no available treatments that could potentially cure them. They've now survived into adulthood and are cured because of these types of treatments. That's how impressive an activity that this type of technology has. The benefit of this technology is that it's highly potent, oftentimes only requires a single dose administration. And because you're dealing with a living drug, right? These are immunologic cells, they can have memory. And so they can continue to reside within the body and continue to attack cancer over time. Then, while there have been successes in blood cancers, some of the successes have not immediately translated into solid tumors like bladder cancer, but we are starting to see early responses in these solid tumors. Yeah, sure. So, as I mentioned before, there is an approved antibody drug conjugate against a target called Nectin-4. And Nectin-4 is actually a very interesting target. There have been several studies evaluating how frequently it's expressed in urothelial carcinomas. And some of the original studies associated with the PADCEV clinical trials that indicate that this is actually very highly expressed in the vast majority of urothelial cancers. And so we've in the lab engineered a Nectin-4 CAR T-cell therapy. And here I'm showing you 2 sets of plots. What we do is we mix these CAR T-cells with a target cell, and we look at the amount of killing over time. And so you can see that in the control, these cells continue to grow and are increasing in number. Whereas in the cultures with the administration of CAR T-cells, you can see that over the course of about 3 or 4 days, the majority of these cells are killed off in the culture dish. We have done a lot of optimization because these CAR T cells require quite a bit of engineering, and we have to determine empirically which is actually the best construct to take forward. And one of the things that we often do is we'll dilute. So rather than adding cells at a 1-to-1 ratio, we'll add the CAR T cells at a disadvantage. So we'll add 1/10 the number of CAR T cells compared to target cells. And so that's what we're showing on the right, where now you see this one line where with the orange error bars, where you can still see killing activity once we've diluted tenfold. And so we've actually selected that CAR T-cell therapy to take forward. And again, one of the tests that we have to make sure that we're seeing activity is in these mouse models and mouse tumors. And so this is actually one of those experiments where we established a subcutaneous tumor under the skin of these mice, treated with a single dose of unmodified T cells, or CAR T cells targeting Nectin-4, and you can see dramatic activity where there's near complete regression of these tumors. And so what are we planning to do with this? Well, we're a little bit concerned because rather than treating advanced disease with this CAR T cell therapy, we want to consider actually doing treatment for more localized disease, specifically the phase of disease that Dr. Grivas mentioned, which is BCG unresponsive, non-muscle invasive bladder cancer. And there are several reasons for this. These CAR T cells are very potent. We know that Nectin-4 is also expressed in normal cells in the body. So imagine if this got out and encountered a normal cell or tissue, it could cause a lot of toxicity. So this approach may actually be a more localized therapeutic approach where we can avoid those types of toxicities systemically. In addition, there is a BCG shortage, so alternative therapies like this may be useful. There's clinical need for additional bladder sparing approaches. We already use cystoscopy and intravesical therapy, so administering CAR T cells through a cystoscopic intravesical approach shouldn't be very difficult for our colleagues like Dr. Wright. And we know that this type of cancer can be responsive to immunotherapies, and CAR T cell therapy is an immunotherapy. And so there's already precedent that these can be responsive. And so, I think we're very excited about these approaches, and with the community that we have here, we can envision that this is going to be translated readily into the clinic over the next couple of years. So I just wanted to acknowledge members of my lab and then members of the bladder cancer group who've been extraordinary colleagues that are like-minded in our desire to really advance the care for urothelial carcinoma. Thank you.
Got time for a couple of questions. In the back, yes. You know what Dr. Lee has gotten down into a couple slides is years of work, and it's just remarkable. So, and really leading the field in this work, incredible.
Yeah, I mean, I think once we get into first in human clinical trials, you know, participation of patients like yourself is certainly very appreciated.
The other thing is he talked about the models that he's using to test these, and these come from patients volunteering to let us have their samples in the operating room or after as well too. So it's not just participating in the trials; it's participating in donating your urine, your blood, your tissue for us to do the work. So good partnership. Question is, how do you volunteer? Talk to your doc. Say, can I give some? So, yep.
John, I have a question here. If you may repeat that. Thank you, Jonathan. So one good question, actually, two questions from the similar. Three questions that come every time. There's more questions. So CAR T cells, are we close to get them into a clinical trial from your lab work?
Yeah, I mean, we also have CAR T cell therapies that we're working on for prostate cancer. Those will actually enter clinical trials later this year. This one is a little bit further out, but we could anticipate that this will probably be 2 or 3 years into the future.
And this answered the second question is how soon?
Yeah.
And in the next couple of years, you think? Awesome.
Absolutely.
And I think the other question is probably also for Dr. Liao. How many patients among all are possible to consider bladder preserving therapy? I don't know if Jay's here. Otherwise, Jonathan, you can comment too.
I think we let Dr. Liao go. I think we think it's about 15% of patients coming in with muscle invasive disease fit that criteria for being a candidate for bladder preservation. As far now, again, there are the patients that aren't good surgery candidates who we still will treat with radiation. But if we're looking at those criteria that he put of a solitary small tumor, completely resectable, no carcinoma in situ, good bladder function, that's probably about 15% of muscle invasive bladder cancer patients. So, all right, thank you. Thanks. Appreciate it. We have one more talk. It's going to be virtual. We're starting with virtual and ending with virtual. So Dr. Sarah Supka is one of also another partner in the Department of Urology. She's certainly a national leader in bladder cancer work and has a special interest looking at resiliency and is doing some exciting research around treatment, surgery, and chemotherapy. And she's going to show us some of her work today.
Hi there. My name is Dr. Sarah Supka. I'm one of the urologic oncologists here, and I also specialize in taking care of patients with bladder cancer. I'm really sorry I can't be there with you in person today, but I'm delighted to have an opportunity to talk to you about something that's really important, I think, for all of our patients who are dealing with a new diagnosis of bladder cancer or a long-term diagnosis of bladder cancer and are facing different treatment decisions. So what I'm going to talk to you about today is something called prehabilitation. I'm going to share my screen, and we'll get started. So the topic I've been given is building resilience before and during cancer treatment, specifically focusing on this concept of prehabilitation. So resilience describes an individual's ability to maintain psychological and physical functioning in the face of stressors, which obviously not only the diagnosis of cancer, but the treatments for cancer are major stressors. And one of the key topics that I work on in my research program is really how can we help patients become more resilient as they're going through cancer treatment. The science of prehabilitation is a really active area of research right now. And you can see here, I just quickly looked at the number of publications on this topic, and you can see that basically starting in about the 2010s, the number of papers that were focusing on the concept of prehabilitation and surgery just astronomically took off. And prehabilitation describes the process of improving a patient's functional capability before a surgical procedure so that that patient can withstand postoperative inactivity and treatment-associated functional decline, or withstand and bounce back from these stressors. So really what we're looking at is trying to pick out modifiable risk factors, try to target those in such a way that we can help make a patient stronger from either the perspective of physical components, nutrition, and there's also a lot of interest right now in how we can bolster a patient's mental capability. And in order to not only improve outcomes after treatment, but potentially improve candidacy for treatment, which is really important. So how can we take a patient who maybe has such a substantial risk profile that they might not even be a candidate for treatment? How can we make them stronger so that they can get the treatment they need for their tumors? If we look at the literature, like I said, there's a lot of papers on this. Prehabilitation before surgery is associated across different surgical fields with reductions in complications, shorter hospital stays, improvement in body composition parameters like muscle mass, which I'll talk a little bit about, lower cost of care, and improvements in quality of life. And this seems to be especially true when we think about personalized prehab, and that's really one of the core areas that I work on. So let's back up the conversation and talk about how we can identify a patient's personal risk profile to guide these prehabilitation recommendations. We are really good in oncology at talking in discrete detail about tumors and talking about the grade and the stage and the risk profile of that cancer. And from that information, we can talk about risks of recurrence, risks of progression, and things like that. But we also need to think a lot about the person in whom that cancer exists, because each individual has a unique risk profile that ultimately will impact not only their ability to receive treatment for the cancer, but to thrive during that treatment. And one tool that I've become very interested in the past couple of years that can help us to identify and characterize a patient's personalized risk profile is the concept of a comprehensive geriatric assessment, which is a multidimensional evaluation that looks at things such as function and ability, the severity of other medical issues that patients contending with, mental health and cognition, and then social networks and needs. And here what we're looking at is we're trying to really sort of globally characterize a patient. We're not trying to reduce them down to a single score. We're trying to understand across all of these different domains, what are the patient's strengths and potential vulnerabilities. And this is important because with this tool, which is so sensitive, we can identify substantial deficits or vulnerabilities, for example, in their ability to perform activities of daily living that otherwise the more blunt tools that we often use, such as performance status, we would miss completely. This is the geriatric assessment that you may see when you come into our clinics now. And this is something that we're utilizing across the bladder cancer program at UW. It's called the Cancer and Aging Resilience Geriatric Assessment, which is it's a self-reported geriatric assessment. It's about 7 pages, about 42 questions. Most patients can finish it in about 10 minutes, and it's a validated, widely used geriatric assessment that captures all of these domains, and it can be completed by about 90% of patients without assistance. So we're using this widely to start to really help characterize a patient's own individual risk profile to help guide not only treatment for their cancer, but also to help dictate the prehabilitation protocol that's going to be most beneficial for that patient. So for example, if we identify functional issues, we can consult our partners in physical medicine and rehabilitation. If we identify problems with how the degree to which other medical problems like heart disease or blood pressure problems or diabetes are affecting that patient's life, we can work with their primary care doctors to optimize comorbidities. We can stop unnecessary medications that may actually increase toxicity and prevent dangerous interactions. We can look at nutrition and make nutrition referrals and also start thinking about specific dietary recommendations that may really help that one patient. And if we identify issues with mental health or cognitive issues, we can make recommendations and referrals to our colleagues in psychiatry or even our colleagues in geriatrics who work with cognition and sort of also maximizing social support to help a patient ultimately get through therapy. So let's talk a little bit about exercise prescriptions. So the goal of prehab is not necessarily to accomplish anything, even like this, even sort of long distance running. What we're really talking about is optimizing mobility, balance, and strength. And this is important for somebody, even whether you are naturally an athlete or whether you're someone who actually is struggling in that domain and maybe needs an assistive device. Prehabilitation is still something that can be titrated or personalized to a patient's individual risk profile. We do functional assessments that look at things like range of motion and ability to transfer, strength assessments and balance. And this is important because especially when we're thinking about potentially abdominal surgery, we want to know about all of these factors for a patient so we can then help patients get stronger. So they're going to be able to get out of bed after surgery, get up and walk around, and ultimately get back on their feet and recover. We look at physical activity as a vital sign. We look at how many days a week patients are active and how many minutes a day. And then we can actually figure out how much activity someone's doing per week. And based on that, we can make a personalized recommendation for how they can start to step that up to become more active in advance of surgery to help people get stronger before we operate. And really what we're thinking about here is we're not talking about going to the gym or doing high intensity interval training or even aerobics classes or anything like that. This isn't about weightlifting. We're talking about giving prescriptions for exercise that are pragmatic and feasible for each individual. They're safe. They should be something you can do at home. They're specific to a patient's needs. And this should be something that's sustainable and not add additional cost to care. We're talking mostly about increasing aerobic activity and sort of general movement. And we're not talking about high intensity exercise. Most of these exercises should be able to be done while somebody's having a conversation. And then specifically, if we identify a specific impairment, for example, in balance, or core strength, we can give you personalized recommendations to improve those. We try to have patients learn exercises before they go through surgery so that they know how to do it before they're in pain. And then we want to make sure that we're learning exercises so that they can be done safely. So this is one example of a recommendation from the American Academy of Sports, the American College of Sports Medicine, which is called the Sit Less, Move More campaign, which is a really basic prehab program. But obviously what we're working on here is a lot more personalized. In terms of nutrition, malnutrition is incredibly common in bladder cancer, and actually severe malnutrition occurs in almost a third of all patients. We notice also that with some of our treatments, we make it worse. So we notice with chemotherapy, some patients will lose a considerable amount of their muscle mass, which is really critical as a predictor of oncologic outcomes after bladder cancer treatments. So we spend a lot of time thinking about how we can prehab nutrition for our patients. And these are some really basic guidelines, but they are incredibly helpful. So the first thing is actually figuring out who is at risk for nutritional deficiencies. And that's where that assessment that I told you about before can come in. We recommend in general a protein intake of about 1 to 1.5 grams per kilogram of body mass per day. And we'll give you advice on how you can achieve that. And we definitely don't ask anybody to diet. We don't want to be restricting energy intake. Beyond that, you'll notice that before radical cystectomy, if you're going through that at our hospital, we're going to give you some recommendations on a specific milkshake that has some specific proteins and amino acids in it that is thought to be helpful before surgery. We also are interested in this concept of immunonutrition, which is proteins that are supplemented with 4 specific amino acids that are thought to reduce inflammation, improve muscle loss, improve muscle sort of protection or reduce muscle loss, and help wound healing. There's pretty good data that this actually can be very substantially helpful. We're also participating in a big clinical trial to see if we can actually learn more about how immunonutrition can specifically help our radical cystectomy patients. The third arm of prehab is really thinking about everything else, mental health and cognition and social supports. And there's a whole movement towards improving brain health around the time of surgery that's being spearheaded by the American Society of Anesthesiologists. And actually just identifying cognitive deficits and mental health concerns and getting patients to the right support systems before surgery can be very helpful in terms of optimizing outcomes. And we also are really interested, again, in this concept of resilience, since we've started doing resilience assessments on a lot of our patients in order to understand their baseline psychometric capital and resilience concerns, thoughts around efficacy and thriving and self-compassion, because these are actually all modifiable. We can help a patient become more resilient, and that's something we're trying to learn how to do better. In terms of what we're working on now, This is a study that I just had funded by the National Institute of Aging that we're going to be kicking off pretty soon, called the University of Washington Radical Cystectomy Bounce Back Study, where we're going to be looking specifically at what happens to a patient's function after radical cystectomy and trying to find predictors of those patients who are most at risk for functional decline to see who we can identify that actually could benefit even more from prehabilitation in the future. And then we're also working with the sports medicine team to develop home-based functional assessments that can help us not only track a patient's function, but when we give personalized exercise prescriptions, track that at home and help give you feedback on a week-by-week basis on how you're doing and how you can do better. And this is something that's actually integrated with the iPhone technology and integrates with our electronic health record. So ultimately, prehabilitation, the potential of prehabilitation, I would say, is a little bit different for every patient because each patient has a different risk profile. But this prehab concept is really the answer when patients say, you know, what can I do? How can I take control of the situation? Well, these kinds of interventions, whether it's optimizing nutrition or exercise or any of these other sort of domains of prehab, this is the answer that allows a patient to assume control and really partner in their care. Hopefully we can optimize patients for surgery and even improve candidacy for treatment in patients who are really high risk to begin with. And again, this is all about also engaging patients in your own care, helping you be a part of the team and really do the best that you can to optimize your outcomes and hopefully at the end of the day, build resiliency. So with that, I'd like to thank you again for your attention. And I hope you enjoy the rest of the day. And I'd be delighted to answer any questions if there are any after this. Dr. Wright and Dr. Grivas can get you my contact information. Thank you. Bye-bye.
Well, we made it. That's the end of the session. Thank you all so much for being here and participating both in person and online. It's really important, as Petros said at the beginning, for you to fill out the questionnaire, the feedback, because it really helps us to make sure we're getting the topics for the future that you all want to hear from, what we may want to spend more time on. So please go ahead and do that. Also, make sure if you haven't done it, you stop by the Beacon spot out there. So thank you to Barb and Gail for being here and supporting. Join up for our walk. If you did our walk last year, this year's at a different site. The last year's site's under construction, under some renovations. So we'll be at a different park this year, but hope you all can be there. And I'll turn it over to Petros to wrap it up.
Thanks, Jonathan. What a day. Fantastic day. It's really amazing to see, you know, so many great people here. Thanks for coming. Thanks for spending a Saturday morning with us. This is for you and we get inspired by you. So thank you, all of you here. And also thank you, the virtual attendees. We have about 80 plus people in the audience. And Jonathan and me, we're trying to answer questions. I think there are a couple of them left. We'll answer them. So don't leave those who are in the virtual room. There are so many thanks to give and so limited time between us and the sunny day outside. But first, thanks go to Richu over here. Thank you so much for all you have done. Tremendous. I think we broke the record of highest attended event at the Fair Hats. Isabel is also here. Thank you, Isabel, so much. And of course, their manager, which is Carrie. Carrie, thank you so much for being here. I think that there is a comment and then I will continue. In 2 weeks, right? Yes, it will be available in 2 weeks, the whole recording. So thank you, good question. So the recording will be available, as Dr. Wright mentioned. Please follow the evaluation forms and leave them with us outside to improve us. Gail and Barbara, you are still here. The BCAN walk is on May 13, and we have a park identified. Continue to thanks, of course, the Fair Hats, a wonderful team for the support. Amanda and Caleb, thank you so much for volunteering today to checking people in. And for all the work you do on research every single day. Barbara and Gail, thank you so much for being here and for all you're doing. And of course, BCAN and, Stephanie, and I think as Jonathan said, Andrea, the CEO of BCAN, will be here for the walk on May 13. I think, of course, the audiovisual support, Zach in the back, thank you so much for all you're doing in every single event we have. I hope I did not forget anybody else, Ritu, please correct me. But again, I think the biggest thanks goes to all of you for your resilience and for your interest and for your inspiration, both people here in this room, your families, and people in the virtual room who attended virtually. Thanks, Mats. Hope to see you again next year. Thank you so much.